Thank you, Chair. I am Francis Mwangi, MCA representing Langas Ward, the leader of minority, and a friend to this committee because I'm so much interested. And Chair, you need to tell everybody that they are all live. So whatever everybody is saying, you know that it is in all corners of this republic because these are very serious engagement. Thank you.
Thank you, Chair. My name is Honorable CPS Samuel Sawe, member representing Kamagut and member to this committee.
My name is Moses Kebenei, MCA Simat Kapsaret, and a member to this committee.
Good morning. My name is Hilary Kipchumba, MCA Moiben, member of this committee.
Good morning, everyone. My name is Mary Goretti Boroswa, a member representing Kipsomba Ward and a friend to this committee. Thank you.
Morning. My name is Patrick Mayo, MCA Moisbridge, and a friend to this committee.
Good morning, everybody. I'm Honorable Thomas Yego, representing Tarakwa, a friend to this committee. Welcome.
Mjambo wote, naitwa Ezekiel Kodingeti, mwakilishi wadi wa Ziwa, rafiki wa kamati hii.
Good morning, everyone. I'm Honorable Naomi Serem, representing gender and a friend to this committee.
Good morning, everyone. I'm Honorable Evelyn Tirop, a member to this committee and representing gender.
I'm Honorable David Piwat Ketanya, representing Sergoit's Ward.
My name is Emmanuel Talam, Sergeant at Arms.
My name is Troy Kimtai from Research Department.
My name is Vivian Rongoe, clerk to this committee.
My name is Honorable Kapkea, member for the Belly Ward.
Okay, all right. Thank you, Honorable Chair. My name is Dr. Kipkemboi Kwatut, CEC for Health.
Honorable Chair and members, my name is Dr. Paul Wangwe, Chief Officer, Clinical Services.
Good morning, members. I am Dr. Evans Kiprotich, Director Health, Preventive and Promotive Services, and for now also Acting Chief Officer, Preventive and Promotive Services.
Good morning, honorable members. My name is Jerry Luvai. I do monitoring and evaluation of health projects. Thank you.
Honorable Chair and members, my name is Laban Kiprop, Acting Deputy Director of Public Health.
Morning, honorable members. My name is Rajab Hadija, the Communication Officer, Department of Health Services.
Good morning, members. My name is Kipsuto Peter, Health Accountant.
Good morning, honorable members. My name is Milka Diambo, Deputy Director Administration, Health Services of St. Bishop County.
Good morning, honorable members. My name is Chris Pascal Masam, Deputy Director, Clinical Services.
Good morning, honorable members. My name is Dr. Sarah Kipkule, Acting Director, Health, Administration and Planning.
Thank you for that introduction. Let us go straight to the agenda that brought us to be in this house this morning. It's almost afternoon. Sorry, members, for the delay. We were blessed this morning to have drugs. That is why we started with the flagging of the drugs in the morning. That is why we had a small delay. Instead of starting our meeting at exactly 10, we are starting our meeting 11:45. Honorable members, allow me to read what we had requested the executive to come and share with us this morning. We had about 4 to 5 agendas. One of the agenda was drugs shortage across the health facilities. We have the issue of quarterly report, which is supposed to be a mandate. We are not supposed to be requesting it. It's supposed to be coming here directly after every 3 months. It is supposed to be 3 months or 4 months, it's supposed to be in the assembly. And then the status of casuals and health care workers. And then another one was to follow up the report on procurement process of health facilities on the development status. So allow me to start with the first one, just to brief us, because that one is already almost done, about the drugs, the shortage of drugs across the health facilities. Why do we have that gap? Because we should not be having even a small gap in our facilities. We have enough money. If it is budgeting, we did a good budget. And what we expected from you is making the request from the KEMSHA when the drugs are still in stores, but not when the shelves are dry. Thank you. So can you lead us on that? CEC and
Yes,
whoever can
okay.
reply.
And Chair, where brief, to give it in brief,
Yes.
let it be, because already we are almost eating time for another engagement in the afternoon.
Okay, thank you. Thank you, Honorable Chair. I think, and honorable members, will go straight to answer the question. I think I will call upon the chief officers to give a brief summary of the history of how we procure drugs and reorder levels and the cycles of actually ordering for these drugs. So I'll start with the CEO for clinical services.
Okay, Honorable Chair, thank you very much, Waziri. Drugs are usually procured from KEMSA, Kenya Medical Supplies Authority. We use the procurement portal called IFMIS. We have a budget of 212 million for the whole financial year, which is not enough, because there is in the neighboring counties there is a challenge of drugs. Nandi, Trans Nzoia, Elgeyo Marakwet. So the border facilities like Moist Bridge and other border facilities have an upsurge of patients. So you get the uptake of drugs in those areas has really increased. And also I feel like because of the improvement of services in Wasingishu, the consumption of drugs is higher. That is what has brought about higher consumption of drugs. Also, opening our facilities to be 24-hour brings higher consumption of drugs. So I would request honorable members that in future we look into increasing drugs budget up to even 300 million, because now we are serving neighboring counties. Then secondly, during the close of the financial year, we consumed the last amount that was in the budget, that was 72 million, to purchase drugs. And the drugs have lasted us for a while. Even what has been delivered today will just last us for a short while. There was a hitch between the 16th and the 26th of this month on the IFMIS portal. The requesters were not able to place their request. That is why the drugs delayed. It was, I think, a nationwide problem. Now the request was placed on 26th, and KEMSA takes almost 2 weeks to pick the drugs and deliver. So that is where the challenge came across. So sometimes the orders can be ready, the request was ready, the requisition was ready, but now the requester could not put the request in IFMIS. Thank you.
Thank you, Honorable Chair. I think I want to give to Acting Chief Officer, Dr. Gabrotich, to say something also.
Okay, thanks, Chair. Maybe to add on what Dr. Wangwe said is that in most cases, we do the order every 3 months. Such that when we do the order, we expect it to last for 3 months. However, maybe on the details of what I want to say is that at times we order from KEMSA. In fact, you will go to their stock status. What they have is what they will give you. At times they have shortages or stock out of some few. During that particular time, you make the order. If they don't have, they will deliver the others. It makes it look like a push sort of system, not a demand-driven. The fact that I will order what I need. But sometimes, maybe we wanted to make an order of, for example, 40 million, the drugs we have just ordered. Out of that, I think 5 million of additional the things we wanted, they don't have, so they did not supply. It becomes a challenge. Going forward, I think for the first time, we've not been having Panadols, paracetamol syrups for children, almost throughout. And you know that's our main supplier. Sometimes you go to a facility, we've ordered the drugs, but that particular one has been missing almost all through because it is not in the stocks of KEMSA. In fact, for the order which we have now, I believe amoxicillin is not there, and amoxicillin is one of the commonest antibiotics we have. Thank God we had enough stocks before. But if we have to go all the way to for the next 3 months, we will probably still run short of it. So, how is the best? I mean, the best way forward for this is the fact that apart from KEMSA, we will definitely be requesting our procurement system so that we get alternative sources. So that when we don't have them in KEMSA stocks, we can procure it from elsewhere. Thank you.
Okay.
Thank you.
Just,
CEC,
yes,
before you move
Okay.
on, if I had the seal, well, that there's sometimes there is shortage with KEMSA. Why are we confined to KEMSA and we have meds? What is the law that pushes us to KEMSA alone?
Okay. Thank you, Honorable Chair, members of this assembly. Yes, it is true. It appears like we are being confined to KEMSA, especially for the last 1 year in this county. We have ordered mainly from KEMSA. Now, there was the law that prohibited counties from ordering outside KEMSA, but we realize other counties like Keyo Marakwet, Nandi, Trans Nzoia, Nakuru, they are ordering from. There is a company called Mission for Essential Drugs and Supplies, or MEDS. So when we explored that one, we were told by MEDS that there was a bill, an outstanding bill of 611 million. But then again, we were advised that there was some audit queries, and so we could not go back to MEDS and so on and so forth. So I want to say, Madam Chair, that there is the possibility of opening it up and exploring so that we don't break the law, and being able also to give, for example, the requirements that are needed. For example, in today's supplies, the paracetamols or the painkillers, they have undersupplied by 5 million. What the governor flagged up in the morning, there is a shortage of 5 million because according to KEMSA, they distribute these painkillers across the nation. So they gave us worth 5 million, so they have our 5 million worth of painkillers. So you can see the kind of problem we are in. Okay, that is.
I think you've gotten what they have said about the supply of medicine. But what I was to ask the CEC was, which law does Nakuru use and Gelgeu Marakwet to get their supplies from meds? If the laws applies to all county government, the 47 counties of Kenya, then which law is cascading was Ngishu County alone not to get medicine from the said place? Honorable Honorable Keitany.
Chair, it was the same issue. I wanted to get some clearances on that issue because when we talk of, there's a rumor that there's a pending of 600 million. Also, there's something audit queries. When there's an audit query, that thing should be done. It should be cleared immediately. It's not that even those who are coming after maybe 2 years or 3 years, they will still go as per the audit query. That was my issue, Chair.
Honorable members, allow me to introduce the members that joined us a few minutes ago from my namesake there.
Okay. Good morning. My name is Honorable Rebecca Cherop, friend of this committee.
I'm Honorable Gilbert Koskei, Chepchiret Kipchambo, a friend of the committee.
Honorable David Letting, Kokwas, member of Kenya Ward. Thank you.
I'm Honorable Cherono Caroline, member to this committee.
Honorable Gilbert Lagat, MCA Kiplombe, member, friend to the committee.
Chair and
You had raised your hand.
Yes, because I can say we are concluding on this matter, because we say thank you. Can they confirm to us whether the arrangement they had made that they stop taking the drugs to the central store and instead adapt a method whereby from KEMSA to various facilities? Is it operational or not? Two, it was the issue of I think nimewasikiza mpaka ikaenda. I think they need to confirm on that, and if they did away with the central store, what are we doing with that facility, because we spend county money? Thank you.
31 million was spent to do that store. I think Honorable Dr. Wangwe can tell us, did the medicine we flagged today go to the facility direct or they were going to stores? Just answer what Mheshimiwa said.
Honorable Chair, thank you. The medicine that was flagged today went directly to the facilities. So a committee of the users and the procurement is usually made composed so that they receive the medicines at the facility. Then on the issue of the drugstore still exists and still has a function. There are other procurements that, other than drugs, that are received at the store and sent to the facilities, especially if there is small equipment. Yes. Yes.
Members, are we done with that? Okay, Honorable Mary, got it.
Thank you, Chair. When you look at the table on the first page, on maybe the purchase and procured drugs on quarterly, we have the quarter 2, 3, 4, and 1. But when you look at the time or the month that separate each quarter, for example, when you come to quarter 2, the purchase is done in November. Then December is like they have no receivables from KEMSA. And immediately in January, they get the third quarter, which lasts for 3 months. 3 good months. And when you look at the amount of money for the 3 months, is around 43 million. But for the 1 month, you have 66 million. And then we have May, June, July. Imagine January is taking 4 months. May is taking 3 months, which is 59. And August, September and October, before you go back to November, it is taking 3 months and it is 40 million plus. So now, my question is, when do you have something that is really balanced in terms of quarters? Because when you say first quarter, second quarter, I think each quarter should be getting 3 months. But unfortunately, 1 quarter here is getting only 2 months. Then there is a bulk quarter that is getting 4 months. I think that is where the problem is. When you overload one quarter and the procurement is very low, what do you expect? Secondly, what is your preparedness? Because when it comes to procurement, it will also depend on how prepared early for you to do your requisition from KEMSA. And I want to believe that the way Dr. Kiprotich has said, that even in this today's consignment, amoxil could be missing. You should not be telling us could be. From your records, you should be telling us amoxil is missing, but not could be. And the reason why I'm saying so is that I want to believe Dr. Kiprotich and the rest of you, we've worked with you people. And you know always the mess that has been in health in terms of drugs. What mechanisms do you have to ensure that we don't lose our drugs, even if they are taken to the facility? What security measures have you put in place to ensure no drugs is taken out of that facility unlawfully? Thank you.
That's a very good observation, Honorable Kuredi. Before you answer Dr. Kiprotich, let me give to Honorable Kapkea so that you can answer those 2 questions at a go.
Thank you, Chair. Mine is on the issue of MET. They've said that there is an audit query or there is a debt of 600 million. But in this document, it is written that the department is working on alternative source with the MET. So my concern was, despite being a debt of 600 million, it means that you are still negotiating with the MET so that we can find an alternative of procuring drugs. Otherwise, because it is written in this document that is that we have, so that you can confirm to us that yes, there is this challenge, but we are still negotiating with MET. Thank you.
I want to add for you another one so that when you answer, you give us the answers. The medicine that we received today, I don't know if we got some vaccine, because there are hotels, supermarkets, they paid money for vaccine and they have not been vaccinated to date. Very soon they are going to take us to court because we have their monies and we have not vaccinated their workers. Instead, I think they have gone to a private hospital to get the medication or to get the vaccine. So my question was, what do you have on vaccine? Thank you.
Okay, thanks, Chair. I think I will answer one or two questions and then I want to talk about the ordering of KEMSA, our logistics management. Normally our quarters runs from July to September, October, December, January, March, and then April to May, to June. What we have given you in that table is the fact that when did we receive the drugs? Also last year, I know obviously there was a challenge of the elections which were there. It slightly interfered with our procurement, our cycle of our procurement cycle. Say that when we order, at times there could be delays, maybe because of BIMI system, because of delays of maybe not available in KEMSA, 1, 2, 3. Such things happen. In fact, I remember for June to August last year, there was a slight delay, and that's why you realize that we receive our drugs in November. Last year, we were added addition. We used to have a total of 200 million for drugs here, but we had a debt. So in fact, when you added additional 40 million, we had to pay a debt of approximately 50 million for the previous financial year. Two is that, as I said at the beginning, it looks like a push shuttle system. When you look into KEMSA LMIS, Logistic Management Information System, the Logistic Management Information System, you'll only order up to what they have. If they don't have, for example, as we wanted to split the 212 million into 4 and make the order. Also, our orders normally in the month of May, June, July, and August, we make sure they are slightly higher because we see more patients during that particular time. So the orders normally around that period is higher than, for example, in December or January. But during this particular time, last year, we had that challenge, and the challenge of also what is available in games. So at times, if the stocks they have is high, we also make sure we order much more. Let me say this, our ordering system is facility based. Each facility makes an order. And we consolidate at the sub-county hospital, at sub-county level. And then we have a consolidated list at the county. Now, the total amount of drugs which we order, if we have allocated, for example, want to order for 40 million, each facility has been given a ceiling that how much can you order. So at times, like for example, now when you are doing the one of 40 million, some facilities will get a higher number of drugs because of the number of patients they see. Some will get very few, depending on the amount of money we want to use at that time. But now for this, we just locked into the LMIS system of KEMSA, and the match we could get is up to 40 million. And then by the time they told us on Friday, this is what we want to do, 1, 2, 3, 4, we realized again there is a shortage of 5 million, what the CEC had already said, shortage of some of the painkillers, which again we are thinking, what do we do with it? So that is some of the challenges we have. Now, when it comes to the procurement, you normally procure in time. In fact, at this time, we are almost like already working on the second quarter of this particular financial year. Once that has been done, if the EMI system will allow, we will make another order, meant for now for October, November, December. But some times we could have the challenges of it means that actually what delayed us for this particular order. Otherwise, the team which is there, we normally make an order and we make sure it goes round. Allow me, the chair, to make a statement about the quantities of the drugs we require as a county. If we use the demand system, what we probably have, I would rather say, we are approximately 40 to 50% of our requirement. The amount 40 to yes. And this, I've done a bit of research in it and even compare others, our surrounding counties. We are almost like, I think we are more by like 50 million in Elgeyo Marakwet County, and yet our population is almost times 2 times 3 theirs. So the same thing to Nandi. What they give is 230 million, and yet still our population is higher. So our orders is higher, is less than our requirement as a county, which I think something needs to be done about it. Thank you.
Welcome, Dr. And before you proceed, we have been joined by Dr. Mayo. Please introduce yourself. Thank you. And we have been also joined by MCA CECM. I don't know, I saw him somewhere. Fine, thank you. Continue.
Thank you very much, Honorable Chair. I will answer two questions. On the question asked by Honorable Kapkea on meds, it's correction, it's 661,000. That is what we owe meds. It is a debt, I think, that has been there since 2017, 2018. The challenge is in the documentation. I think there is a delivery note that was not given by meds, so it's a challenge to pay. Although we are in discussion with meds and we are really working to resolve the matter. On security measures, we have had security measures on drug pilferage. We have had training of facility heads, and we are trying to really empower the facility heads to own the facilities. Then again, there is close monitoring by the sub-county team, sub-county pharmacists. There is close monitoring of drugs and reports given to them monthly. So the issue of pilferage, I don't think it is rampant in Uasin Gishu. I don't think we have a problem. Then, just to add on the other question on vaccines, vaccines were in this order. Then the other question on how there is a variation in terms of drug ordering. In some months you get consumption is higher than other months, especially now that we have the rains and El Nino. We expect antibiotics that cover respiratory infections to be, the uptake to be more. So as a department, we will handle that as an anticipation. Thank you.
Thank you, Dr. Members, I think let's Honorable Kimayo, and then I'll come to you.
Okay, thank you, Chair. Mine is just an observation, and I wanted to ask just a simple question, because I've heard them sharing that each facility makes an order to the KEMSA. But then taking an example of Moy's Bridge facility, where the sick people are just given antibiotics. Those are the drugs found there always. And then they are told these others just go and find out in other chemists. So have you checked what happens when they order the medicines, especially those ones which deal with more than the antibiotics, because only antibiotics are found there. Mostly that is what is prescribed to the sick people. And that was the cry, and always the cry in Moss Bridge. I think I shared with the CEC about the issue. And if you go to the facility and you become hot, you quarrel them a bit, then you find the medicine is there. And Dr. Wangwe has said they have put checks and balances to make sure we don't have such problems. I don't know when will you arrest this problem so that people get drugs according to how it was ordered in the facility.
Thank you. Let me get also from Mheshimiwa from Cheptiret, Gilbert, Honorable Gilbert.
Thank you.
And then you can answer both.
Thank you, Chair. One, I just wanted them to confirm for us, is it 661 million or 661,000? That is the outstanding.
1,000.
1,000. Thank you. 661,000. Another question. Since, to fertilize on the question Honorable Koretu had actually asked on the variants, since you've noted maybe during the raining season, that is the time that you use a lot of drugs, what have you tried to do? Say that you encourage, or maybe there's something you are supposed to do to encourage that, to prevent the occurrence of such that demand at that time. Because I think there should be something you are supposed to teach these people for the say that maybe they are supposed to do so that they don't get sick at that time. What have you tried to educate them on?
Thank you. Daktari, you have heard what the MC has said. What we are saying is, what are we prepared for the rains that we have? Because we always know when there is rains, when there are rains, we have a lot of stagnant water, and the malaria, and also maybe any other diseases that comes with a lot of rains. So I don't know, what is the preparedness in your department?
Thank you very much, Honorable Chair. I will respond to the question on Moist Bridge first, and Dr. Kiprotich will respond on preparedness. On what happens in a facility when drugs go low, there's something we do that is
drug redistribution. That is why you find drugs appearing, because we have redistributed the drugs. Sometimes an uptake in one facility can be more than in another facility. So when drugs go low, we redistribute across the sub-county. But we can assure you that no pilferage. There is no pilferage of drugs. If at all, then it's very minimal. But that is, we do drug redistribution. Sometimes you may even get the data from a facility, and the needs of that facility change. So for example, if we have been taking, just an example, maybe 1,000 doses of amoxicillin in Moist Bridge, next quarter they may take less or more. So when that happens, we do redistribution according to the variance. Thank you.
Okay, thank you, Chair. I will try to answer one of the questions, especially about the Moist Bridge, which also applies to almost all other facilities. In most of our level 2, level 3, even level 4 facilities, the commonest condition, we call it morbidity in our settings, is more of bacterial in nature. Being bacterial, it means we use a lot of antibacteria, which are basically antibiotics. In fact, up to 90% of our patients come with infections. Therefore, most of the drugs we tend to order is to cover the majority, which is the patients with bacteria. Call it pneumonia, call it diarrhea, call it wound infection, typhoid, brucellosis. All those are bacterial infections. So we must be quite prepared. In fact, generally in the third world countries, our biggest headache is bacterial infection. In fact, if you look at our top 10 diseases, there is none which is non-bacterial in nature. I have not gone the top 100, the top 10. So I'm talking about 90% of the conditions needs antibiotics. Some of them are viral, but because we don't give antivirals most of the time for normal flu and all that, we only protect for bacterial infection. So we realize that we do order a lot of antibiotics. Now, in the last quarter, the supply, I'm looking at the details. I know we missed a lot of anti-allergies, because when it comes to the rainy season, people also develop allergies, asthma, sneezing, all that. It was not there in the cancer list. The pharmacist with us here, I know she can confirm that. So at times we make sure we've treated you, syrup, Piriton, syrup, cetirizine, and all that. The other year we had at times we run short. We don't get when we make the order. It gives us some few challenges here and there, and those are realities. Like that, when they are missing in KEMSA, we need to look for alternative sources. Otherwise, we have constant drugs, which basically we supply almost constant, like antihypertensives. The numbers don't increase rapidly because we could be identifying up to 10 maybe in a whole month or so. So generally the order does not change so much compared to antibiotics. Now let me say this. In some areas, for example, Moist Bridge, Tarbo, and more of soy and the Tarbo sub-counties, malaria cases are higher, for example. When you go to Ainabkoi and Moiben and those other sites, you might not get a case of malaria. So when you are making the order from the facilities, you will realize some areas put a lot of effort to antimalarials, while others maybe don't. But there is no facility which is not order antimalarial because we are in a malaria zone. So during the times of malaria, you will realize there is shortages, for example, in Tarbo. So we'll have to go to burn forest and pick those particular drugs and to bring to these other sites. So these are the things we make the order. But let me say this again, from a biological point of view, sometimes diseases are unpredictable. You will be there today. The other day we were told the number of cholera diarrhea cases went up. We didn't anticipate that. So occasionally we are in shortages. So we go round collecting, and the work of the sub-county pharmacists is then to be crucial during those particular the times that we have to pick from here and here to make sure we have covered these. Otherwise, we normally do prepare. We have a disaster or disease outbreak management team. In fact, we do surveillance and we plan for them. Whenever we notice there's something upcoming, we sit down as a CHMT and plan for it, and maybe pick drugs from here and there to make sure we have covered that particular site. Thank you, Chair.
Thank you. Allow me to give Mary first, and then I'll get back to you.
Chair, my question is that you've given us the order that you do on quarterly and also the amount of money you spent. I would wish that also when you are doing this, you give us, because you say the order comes from every facility, can you also break down to what amount does every facility take? Because I think that one also will help us in terms of not to be doing a redistribution of drugs from one facility to another, because that is where the loophole comes in terms of theft of drugs. Somebody may come in a pretext that facility A is lacking certain drugs. How do you really identify that this facility has more so that you do what we call redistribution? I think we should stop that kind of business. Every facility does by its own demand. It is demand driven. I don't know how it comes again, others get more. At the end of the day, it is distributed to others. So we need to have the procurement per every facility. Because when the drugs are not in a facility, the in charge is the responsible person. Because when they are doing the orders, why do they do less? So that other months are remaining without drugs. People are suffering. They are being told to go and buy from a certain private sector. And again, you as the people, the custodian of our facilities, why should you allow your officers to be redirecting the patient to a particular dispensing facility, which is a private? And when we follow it up, we realize it is for one of you. It is a business you are doing. Thank you.
Thank you,
Gilbert.
Thank you, Chair. Langu nafikiri CEO amejibu, lakini ningetaka tu afafanue, although hajajibu juu ya prevention, si ndivyo? Hajajibu hivyo. Kuna kitu Bishop amesema na ukitoa macho dawa inafanya nini? Inapatikana. Distribution yenyu, is it in terms of kuna drone inaleta or, kwa sababu amesema ukitoa macho inafanya nini? Inapatikana. Redistribution, how long does it take? Dawa itoke from one corner to another.
Tanipatie Honorable Cherono, kisha Mheshimiwa Chepkonga atasema.
Thank you, Honorable Chair. I've been listening to our conversation with the CEOs and our CEC and the other officers. And important to note is the role of KEMSA in crippling our operations in this county. And that is basically through the eyes of a monopoly. I think the biggest antidote to that is to get another supplier on board as soon as possible. Surely, we cannot be talking about 661,000 that cannot be paid for whatever reason, that is then translating to a huge loss in the supply, in the provision of the health service to our residents. There is no way 661,000 is going to call the shots 1 year down the line and more days are being counted. It is something that ought to be addressed with the urgency it deserves. If it's bringing a supplier like Meds on board, better be done soonest. For whatever reason, let's not talk so much on, the challenge of the amounts that are being owed to them. I think there's something that can be done, and I am tasking through you, Chair, that the responsible officers take charge of that. Secondly, is on the pilferages. I'm glad that seemingly our CEO on clinical services has taken charge, and he has observed that there has been a limitation to the pilferages that we've witnessed in the past. However, he left a percentage of a possibility of pilferages. The percentage might not be as much as before, meaning there might still be some degree of leakages in the system. So my question is, how far is the drug management system that had been proposed earlier? How far is it? And my concern, even as the system is being put up or has been put up or is in the process of being set up, is for it to be end-to-end, so that we are able to track the drugs all through the inventory system to the point where it gets to the intended user. During my earlier conversation with one of them, I was telling them the other area that we really need to be keen on is the leakage at the end, whereby it might not be the intended patient who goes home with the drugs. How then do we ensure that we are not only controlling the stock, but it actually gets to the right patient? How do we ensure that if it is, let's say, patient A who was being treated, it's actually patient A who has gone home with the medicine or the drug? So I would like to know how far the drug management system is, the tracking system. Thank you, Chair.
Mheshimiwa Chepkonga.
Thank you so much, Madam Chair, and I want to appreciate your presence here from the Department of Health. I have two issues. One is whether we, as a department, you have a system called pharmacovigilance, and whether that the management, if it is managed through the entire county or sub-county level. Number two, I'm worried that if you are here today to tell us that we failed because KEMSA failed us, or because we have 600,000 that we owe maids, then are you asking us that we all fail? That is now, because you are saying the department failed, so are you asking us that we own the failure? That is the Assembly of Uasin Gishu, combined together with the Department of Health? Because it is very unfortunate that some essential drugs are missing in our dispensaries. It should not happen during the regime of Gilbert, Honorable Chepkonga. Madam Chair, I am asking that we do not fail on that. Because they have failed to take charge on the officers on ground, then we will do something about them here, today. Thank you, Madam Chair.
Madam Chair, can I interject a bit?
Before you interject, I want you to take notes, eh?
After.
It's okay. Let me give the CC first and then I'll come back to you, Mr. Honorable Yego.
Yes, Madam Chair, I thank you and the honorable members. I think I want to say that one, the fears of the honorable members, I don't want to say are unfounded, but I want to say that one, we are not saying there are no pilferages, but we are trying to manage. How are we managing it? We are having plans to digitize the inventory, what we call commodity inventory. All what you saw today being flagged will be digitized from source, meaning we'll work with KEMSA and the government's policy and law on digital health so that we are able now to digitize everything in health, including patient records, everything, information and so on, including now commodities or drugs like what we have just said. So we are in the process of, for example, you may also be aware that the county is working on what we call, like today, Madam, we were being asked to, there's training going on a revenue management system, which is new. There is also e-information system for the county. And you have also seen fiber optic that is running to all facilities that is going to help to make everything digital. So we are hoping sooner than later to be able to digitize all products that go to the people. And what Honorable Cherono said, how sure are we that the drugs actually go to the right person? So that is going to be something we are going to ensure in the new system. That is number two. Is something which is not going away, the issue of meds. I agree. I presented before this Honorable House at the beginning of the year. It's now almost 1 year ago. I want to say that we take the bull by the horns and we go back and make sure we pay meds. In fact, in the morning we were with the Honorable Chair, and when the County Secretary was saying meds can be paid, it can be sorted out, it can be an alternative, because I want to concur with Honorable Member for Inapkoi that it is failing to take action. It's failing the county, it's failing the assembly, it's failing all of us. So I agree. We are going to go home and ensure we pay meds, we have meds as an alternative, and so these excuses, we shall not bring them here, if you will allow us, honorable members.
See, I expected also you to tell us about, I think one time we were here, yes, and there are some medicine, when they get to the hospitals, they will not be in the shelf more than 2 days, especially the most expensive antibiotic, the Augmentin, Glavlin, or I don't know the names, but those expensive antibiotic, it gets to the facility, and the next minute, it is not there.
Yes.
And the only antibiotic we can get in our facilities are amoxil and I don't know the names because I'm not a medic. And that is what Honorable Cherono was asking. Is it getting to the user?
Yes, I think I will allow the county pharmacist, but
yes,
the point is, all health facilities Like you have said, it is actually ordered from facilities. So certain facilities don't order certain medicines because it is assumed certain diseases do not require those medicines at that level. So as you go up, you order certain medicines and so on. So I agree with you. Let the pharmacists speak to that. But it is true, it used to be that in the past, when we found, you remember we went to Kapsaos, what do you call that dispensary?
Biemit Health Center.
And then we found some vaccines that had been ordered and had been supplied, and somebody was coming with a motorbike to take it and so on. So I think that one has been reduced, as the CEO was saying. It has been eliminated. And for Mheshimiwa, for Moist Bridge, I don't want to say we will not come back to Moist Bridge. We have to come back. We have to do a study there. We have to ensure what you are saying must be sorted out so that if there is an element in Moist Bridge, we should be able to root it out. So I don't know. I want to say, yes, we have heard you. We will do something about it. So maybe the county pharmacist to speak to.
Will speak to it.
Yes.
As she speaks to it, I want also to add something to her before I give Honorable Yego. When Daktari was...
Point of order, Madam Chair.
Yes.
As we continue with this agenda, please be a good timekeeper. We should not dwell on one agenda for the whole day. Thank you.
I want the county pharmacist to tell us how much is enough for medicine, because we were told by Daktari here 200 million is not enough. And yet we have been doing budget here. And nobody has brought to this house that 200 million is not enough when we are having 800 million for brick and mortar in our in our hospitals. It's like we are concentrating much on constructions than medicine. Yeah? Please. Daktari Eunice.
Thank you, Chair. Okay, I'm going to start with number 1. The question was, how do the facilities make their orders? It depends on their workload. And their workload, I mean the number of patients they see every time. And they keep this information in a logistical system that is online. So any other time we want to make an order, we share the amount with the workload of each facility. Question number 2 was about the redistribution, which is based on the needs of every facility. So
maybe, Chair, I need some clarification on that issue of making orders. Take an example, a place like Chepkanga. In case the in charge says maybe he or she handles around 1,000 patients. We have the one for Tuganestet. Maybe they handle around also, they might say also 500. Are you going to give those people as per their order? Or maybe you'll say, because of the amount, we are going to reduce. And if it is true, you are going to reduce because of the figure, now that you have around 200 million, instead of more than that, as per the CEO, what is the formula that you are using?
So we equate the total number of the workload to the total amount of money that we are going to use. And then we say, if, for example, Chepkanga has maybe 1,000 patients, then their amount is going to be higher than for Tugen Estate. I'm hoping I'm answering.
Maybe, Chair.
I think we are not together on that. When it comes to figures, I think what I was after is the formula. Yes, Chepkanga is 1,000.
Yes.
Tugen Estate is 500. If you go to maybe Pioneer, they have 1,000. If they make their orders as per the number of patients, then it means it might be even 500 million, and yet you have 200 million for the whole year. What is the formula that we are using?
Maybe, Chair, can I assist?
in answering that question. It is proportional to the number of patients. So we look at the total number of patients seen becomes the denominator. And then your facility, if its total patients are 100 and you are seeing 10, so it will be 10 out of 100 times the amount you are given. So it's a proportional, you are given drugs proportional to the number of patients seen. The denominator is the total patients seen in the county, in our facilities, and the numerator is the number of patients you see now times the money you've been allocated. So it's purely a proportional figure. Number two is that, as I said at the beginning, the amount you have allocated to the drugs is far lower than our requirements. So we will, at the end of the day, look at which specific drugs, we consume more than the others. So you will realize the way Honorable Member from Moist Bridge was saying is that you will put a lot of emphasis on antibiotics, maybe painkillers, antimalarials, depending on the season, to better that. Otherwise, if we say we want to order all the drugs we want to order, the amount of money you've allocated is just like a drop in the sea. It's small.
Through you, Chair, on that note of the number of patients being seen in the facility, that is the approximated catchment population, Dr. Rotich?
Chair, no, it is the total number. It's the exact patients you saw in that facility. So we consider how many patients did you see, for example, in the previous quarter, versus the total patients seen. It will give us a proportion, and that is what they use. It is automatic. It's an online system.
I think, Dr. Eunice, it has been answered. Eh? So what I had asked you, honorable members, I would like, when we'll be doing a supplementary budget, I would like to have Dr. Eunice with us so that she can tell us what is enough for her. We don't want, again, when we have another meeting, we are told 200,000 is less 200 million.
Correction, please, Chair.
Yes.
During budget making process, the process starts with the department.
Exactly.
It's upon them to give the proposal, what is enough, and they come and defend that. It is not for her to be, it is to start from the department. Thank you.
No, Honorable Chair, thank you. But it has been, that has been the tradition. But I am making a humble request that when we'll be doing our supplementary budget, let her present what she thinks it is enough for her, so that we are not told again next time the medicine is not enough. Yeah. Thank you, members. I think we have a lot of agendas. I believe all of us, we have...
Maybe parting shot.
I want to give, Honorable Moya, I will give you the last. Allow me to give Honorable Yego and then Honorable Evelyn to finish on that part, and then we give Honorable Moya, so that we go to the next agenda.
Thank you, Chair. I think mine was only to follow up what Honorable Caroline had mentioned, and the way the Chair, the CEC has mentioned, or try to give the answer to that. The CEO mentioned about the neighbors, and we are talking about the drug going to the exact patient. I don't know, Chair and the department, what are we going to do? Because we are seeing the consumption of these drugs, maybe the rate is maybe high, and one of the reason is because of the neighbors. Maybe the neighbors are coming. So, what actually has the department going to look at that on how you are going to handle these neighbors? Not to an extent that the locals are disadvantaged. Kindly.
Thank you, Honorable Yego. Let me give Honorable Evelyn.
Thank you, Chair. Okay, thank you, Chair. I think we had a question which we asked, and it wasn't answered by the CEC and the CEO. We said we will be distributing the medicine directly to the facility. So which criteria are you going to use to ensure that all facilities have equal distributions? Thank you.
finish so that the answer we go to the next agenda.
Yes, Honorable Muya.
My issue was they need to tell us how have we done about the revolving farm pharmacies. I know when the new government came, the governor reintroduced what had been closed by the previous government about revolving farm pharmacies, which helped most of our, they call what diseases? Yes, chronic disease management. We need to hear from that because it's so dear to our people. And finally, during next presentation, I would like to hear from your committee how they are thinking. I have been saying that there is what we call faith-based facilities. For example, Catholic has so many health facilities. They serve our people. But the drug issue is all over. I know there are counties whereby there is a memoranda where the government enter into with these facilities because they are serving our people, the great people of this county. How can the county government help them in maybe giving them the drugs? Because maybe it is only that faith-based facility that is near to our people, giving the same services. Is it possible? Is it not possible? They need to, not to answer today, they need to go and sit as a department, think over it, and see how we can maybe talk about it. Thank you.
Daktari or CC to answer us that one.
The faith-based, or which one?
Both questions asked by Evelyn, Honorable Evelyn, and Honorable Muya and Honorable Yego.
Maybe before I answer that one, so that I finally conclude, I want to give the CEO to just mention a bit on what the members have said, and then I will talk about what the new legislation is, which is coming about the faith-based and private entities.
Okay, thank you very much. I'll respond on revolving pharmacy. KEMSA gives us drugs which are essential, very basic drugs. The revolving pharmacy offers a complementary option for the non-communicable diseases. Some drugs that are not offered at KEMSA, they have set in the sub-counties and they are really assisting us a lot. On the part of distribution, the fair distribution of drugs.
Maybe, sorry, Chair, because it is not offered in all facilities. Do you have plans to increase the revolving farm pharmacies? Because I'm sure it is not all over, and they help our people. Thank you.
Yes, we will.
Yes. Maybe I should come in for CEO. Revolving fund pharmacy, as per the definition. You remember when the governor came on, came to in office, the revolving fund pharmacy had been closed by the previous administration. You remember this. Now, revolving fund pharmacy, as per the word, is a pharmacy that is funded by an entity, for example. So in this case, it was AMPAT. So because of the differences, which we don't know, when we came on board, we opened 6 revolving fund pharmacists within the county, mainly in the sub-county hospitals. Remember this. So what these pharmacists do is to purchase or acquire drugs that are expensive, so to speak. For example, for non-communicable diseases, that is pressure, sugar, and so on and so forth, mainly. And on top of that, it also has other drugs, which once in a while our pharmacists may run short of. And so because these pharmacies, the revolving fund pharmacy charges money, it charges money which is slightly more than what we would normally charge, because you know in level 4 we charge. So these revolving fund pharmacies, we are rolling it out to other 10 sub-county, not sub-county, level 4 hospitals that will be elevated in the county, because right now we have 6 sub-county hospitals and we are planning to elevate another 10, which we shall have revolving fund, and which HAMPAT is funding. Now, the county will continue to increase the level of funding, which the CEO has said from 200 million, and we were with the governor in the morning and the chair, that we will initially maybe come in the next supplementary budget, put in maybe 50 million. Because we are realizing for sure we are running short of drugs if we continue using 200 million thereabout. So that is something, a discussion which has to go to cabinet, but chair and myself and governor, we were in agreement that 200 million is not enough. So revolving fund pharmacy is something we shall also pursue with AMPAT as an alternative to our pharmacy. Because sometimes, for example, people who have, it's clear. Thank you.
Dr. Wango, do you have anything on Masam?
Yes. Thank you, Honorable Chair. Maybe to respond on the issue of the contribution which is made by our neighbors, is that, Madam Chair, whatever sells best attracts more clientele. I would like to appreciate the leadership of our county for actually ensuring that we have enough drugs despite not being enough. This has compelled actually our neighboring counties to walk to our facilities and get services. And at the top of on the list of our facilities is Ziwa and Ban Forest. Those facilities receive a high number of clients from our neighboring facilities, courtesy of the good services that we offer. Remember, Honorable Chair.
Maybe point of order, Chair. Maybe unless if they can confirm that it is true we have patients from other counties, and if they can confirm that there are more than the patients who are going to other counties from Uasin Gishu. I am saying that because my ward, which is a neighbor to Elgeyo Marakwet, most of the time they go to E10 referral. So let us not, because this thing is life, it might sound as if I think you are getting what I'm saying. It might affect my people.
On top of that, Chair, people from my ward, Kipsomba, most of them go to Lukiani, that is Western. We go to Kongoni. We go to Kibunguchi. So now, when you are talking of people from other counties getting services from our county, also our people are getting services from other counties. And remember, our people even prefer going to Western hospitals because when they go there, it is a one-stop shop. But when they come to our facilities, including Siwa, imagine Siwa level 4, somebody is still being referred to go to a pharmacy, which is a private one. So when we are talking of drugs, what I would really want to say, it is not a matter of we have less money. The problem that we have in our county is that we don't do screening. We just attend to the patient from the way he has presented himself. We don't screen, so sometimes we even give wrong medication, which will escalate the sickness to another level. And that's why we are consuming.
The point of order, Madam Koredi, I don't believe our doctors in Uasin Gishu County give wrong medicine. I just want you to withdraw that one. It could be a slip of tongue.
Chair, I am very clear on what I'm saying.
I request you, Honorable, to withdraw that, and then you continue. Remember?
Maybe I reframe.
Reframe it and use a better language.
Yes. What I would say is that, Chair, you can imagine in our facilities, we don't have labs. We don't have lab technicians. So when you are prescribing a drug or a medicine to a patient, what parameters do you use to know that exactly this is what the patient requires? Sometimes I'll prescribe, I'm having an headache. You give me painkiller. And yet the whole problem is in the stomach. That is what I mean.
Otherwise,
Thank you, thank you,
Thank you.
Mheshimiwa. I want to close this agenda number 1 because we have dealt with it for more than 1 hour.
The last one.
Leader of majority, as you introduce yourself, just say,
Thank you.
Honorable Chepkonga, what do you have to tell us?
Chair, Mr. Massam, you know, we are all lucky that we are members of Uasin Gishu, especially the honorable members represents members of Uasin Gishu. So please, when you say that your hospitals are preferred hospitals within the region, then please convince us that that is true. Because yesterday a patient from Mainakwe came and could not find services in Band Forest, all to referral hospital. Mr. Massam, please, you are talking to people who reside in those villages.
Thank you.
Your waziri, our waziri, sorry. Our waziri is a member from Mainakwe, and his family would prefer to go to Elgeyo Marakwet for medicine than the place he leads. So please,
So
that is
we
why I
should-
came here today.
So we should stop
Maybe honorable
ting
member,
and make sure we say
protect
exactly
me-
the problem we
protect me
have.
from
I am
the
protecting
member
you.
from Mainakwe because
I'll protect you.
he's
That is why
insinuating
I've
something
interjected.
which is not very correct. Thank you, Chair.
Thank you. Mheshimiwa, neno moja tu alafu leader of majority tumalize hiyo agenda ya kwanza, twende agenda ya pili. We still have another 3 agendas, and remember at exactly 2 we have another committee.
Asante.
So please.
Asante Madam Chair. Langu sijasikia majibu ya yale yote ambayo niliyauliza, sijasikia majibu zote. Alafu lingine lenye ninataka kusema. When I like mathematics so much. Ukisema kwamba you are using denominator kama the total number of patients, ujue kwamba kuna wale watu wenye Mungu amewachunga hawajekuwa wagonjwa wakati fulani, ndio wakuwe maybe at that time. Do you consider that is the reason as to why wanaenda kwa like now yangu Kaptumo wanaenda Katuya? So you could give a lot of dawa ziende Katuya in hali ingekuwa ya Kaptumo. I think there is another formula which should be implied, not that this one is the final.
Let me give Honorable Sang, who is our leader of majority, and then Dr. Kiprotich, you will answer, maybe all of them.
But maybe, Chair, so that the member can be assured, maybe those questions are even missed, even me. Maybe you can say it again.
Okay,
please.
okay, fine. So Honorable Sang, just wait. Dr. Kiprotich, please, just answer him and then, so that we cannot forget.
I think he asked something about pharmacovigilance at the beginning. We do. In fact, in every facility, we have a tool to collect that. Pharmacovigilance basically means that we make sure that the drugs we are using are safe. And in case we suspect anything abnormal, we report. We do that. We do that from right at the facility level, sub-county, all the way to national. So we do a lot of pharmacovigilance from the technical point of view. I don't know whether that is what you were asking, but we do. Any patient who reacts to a drug, we report accordingly. And we've trained our staff, both pharmaceutical staff and the clinical nursing staff on the same. So we follow that closely. I want to, from a doctor's point of view, because I am one, is the fact that we have qualified staff, a number of consultants, a number of MOs, nurses, and all that. We manage our patients well. From an individual point of view, I think the staff we have, in case of anything, we really follow them up to make sure that in case, if in fact a patient is mismanaged and we get that, we do the necessary following. We follow it, following either protocol of nurses, doctors, and all that. We do follow. Obviously, we have around 170 dispensaries. Most of them probably might not be having labs, which I think is universal. We have higher number of health centers and dispensaries than our neighboring counties. health centers than our neighboring counties. So I believe our labs could be more than the one in Nandi, the one in Trans Nzoia, the one in Uasin Gishu. So I want to say that I believe we are better than them.
Kindly, do you want to tell
Thank you,
us?
Daktari. I
through
think
the
you have
chair,
answered.
kindly.
You have answered correctly what he wanted to hear, and also what Honorable Chepkonga was talking about. Because many a times we do hear that our people from Uasin Gishu County goes to our neighboring counties for medication.
Yes, Chair, let me say this, that one of the rights of a patient is to choose where to go. Even me, when I get sick, I will really decide
order,
to choose.
Chair?
Yes.
Yes. Our patients do not choose where to go. They only choose if they know that when they go there, they'll get services. They are looking for services. It is not that they choose to go to Western. In fact, the distance is very far. But because they are sure that when they go there, they'll be given services.
Point of
Thank
order.
you. And,
Point of order, Chair.
What is out of order?
It would be better if you let him finish the statement because he was just cut short.
Yeah, yeah.
Please.
Yeah. Okay. Thank you. Chair, I got an opportunity one time to work in Tarbo and also work in Pioneer Health Center. When I was in those particular sites, in Pioneer, for example, I could see patients all the way from Kabiemit, from Dalat, and all that. When I was in Tarbo, we could occasionally, because we did not have an ultrasound at the beginning, they could go to Lumaganda. But they used to come for X-ray from Tarbo to Tarbo. What am I trying to say is the fact that sometimes patients follow. I got some patients at times in Pioneer who are from Tarbo because maybe the staff, 1, 2, 3. We could wish as much as possible. In medical field, I'm told if you are 3 doctors and you come as a patient, we totally will not criminalize you by choosing one of us to see you. Same thing applies to the facilities. And if we could respect that, the better. But obviously, we could wish to make sure we have the services the patients require for them to come. Because if we don't have that, the patient will go elsewhere. Thank you.
Wacha nipatie nafasi kiongozi wa wengi.
Thank you, Chair. First of all, let me apologize for coming in late. I was caught up with other functions. So I am going to be very brief. Number one is to appreciate the team. Thank you, Waziri, for coming along. We have had other departments, Waziri excusing himself, and from the assembly, we are saying this is exemplary. Thank you for coming. Now, I have 2 issues on the issue of drugs. Number one is in the last few days, in the last few weeks, we have had problems with, in our facilities, accessing syrups. I don't know if that was across all the facilities, but in the few facilities that I visited, there was no supply of syrups. And the reason was, I was told KEMSA did not supply syrups with the general supply. So I don't know what happened. Did we not order, or there was no, it was not available at KEMSA, or I don't know what happens. Number 2, Chair, is that we have seen a building at the district hospital coming up at the corner, and we are hearing that it is going to be a dispensing pharmacy for visiting patients, not our patients in the district hospital. We'd like to hear that explanation, because I ultimately think that will need a policy, because it is not like the normal pharmacy that we have in our facilities. So thank you, Chair. I said I was going to be very brief.
Dr. Wangwe or CC, please.
Thank you very much, Honorable Chair. I'll respond to both questions briefly. The syrup was out of stock in KEMSA, but currently they have it and it has been supplied. Then secondly, on the pharmacy at the district hospital, yes, it will need a policy, which we have. It will need a policy, which as a department we have worked on, and it's just yet to be forwarded to the desk of the CEC for onward consideration. But what will happen is that the outlet will be shifted to face inside the hospital because of an advisory that we got from the Pharmacy and Poisons Board. It is going to be an NHIF pharmacy, specifically NHIF, a cashless pharmacy that will serve NHIF and other insurance patients. That will also solve the issue of drugs, where you may get some drugs not available in KEMSA. Other drugs, again, even if we follow meds, we may still get some shortages in meds. So that will at least close the gap, of course not in the whole county, but at the facility there. Also, the whole idea of having that pharmacy is to look at the issue of healthcare financing, which is a challenge generally. If you look at the district hospital, it has a debt of 10 million shillings. Yes, which we are working as a department to close the matter, but having an NHIF pharmacy there that will serve NHIF patients.
Point of order, Chair.
Yes, please.
By meaning a debt of 10, he need to be very clear.
Yes.
Debt to who?
To suppliers that has been accrued over the years. Yes, please.
Honorable Naomi.
I have one question about that pharmacy. Who is going to stock that pharmacy?
In the policy, we are going to, the department, the health department will budget for the pharmacy and stock the pharmacy. The policy is still being worked on and it will be tabled.
Chair. No, let it be clear.
I want it to be clear.
Debt. How did it accrue?
And I want now here 10 million. I want him to explain.
Yes.
But before that, I want Honorable Kipchumba from Kapseret to tell us what he has.
Yes, thank you.
Because it's like this one is.
Yeah. When the CEO was talking, I think there's something that captured my mind concerning NHIF. Can you clarify something about NHIF? Because I think in this county, we are, if I'm not wrong, the county government hospitals, we are not capturing the NHIF. Are we using the NHIF maybe for the services that the great people of Wasingishu are going to the hospital? Are we getting any money from NHIF to finance our department?
Now, I will start by
10 million.
Yes.
Debt.
Yes.
That
now,
is.
Your Honorable Chair, this is a debate that definitely had to come out. We had to come out open as a department. These are debts that have been accrued over years in all these facilities, and we have to find a way of resolving. Health is a consumer, so we have to think of other ways of ensuring that healthcare in Wasingishu is, we can actually, the process is smooth instead of it being a consumer. Hoping that the FIF bill will come and resolve the issue, healthcare is continuously being a consumer. That is what grew over the years. But I'm sure as a department will solve the matter.
I'm not satisfied. It was a supply of medicine. What was it for? Because that is what the members want to know. It is not clear.
Yes. In a facility, there are many suppliers. We have the people supplying the lab registers, the security company that was locally outsourced then, but now not. Water. These are issues that have accrued from all the way back from 2017.
The chair.
Yes.
Maybe chair, CC, let me.
Just a minute, Honorable Koredi.
Let
me give him. Maybe he knows more about the 10 million debt.
Yeah, Honorable Chair, I think what the CEO is saying is not something we have discussed at the departmental level. One, we even don't know the breakdown of those debts which have been brought forward and which the CEO, if he had asked me, I would have told him not to say it here because it is not something we have discussed. Number two, as much as he has said there is 10 million debt, I know we, in the previous regime, we have paid close to 70 million of what we were calling accruing debt. Wanaita nini hiyo deni ya the one that was the government gave 1 billion to pay off. So in the county we paid close to 70 million, but that is something which had to come to cabinet. And so this is something which I'm yet to be privy of, and we will be able to advise the House.
Maybe to cut that issue short, before they pay, Chair, we need the breakdown, who brought it up, because if somebody did not use his office or her office well, we have to crack the whip as an assembly, because we are not here to entertain such.
I agree with what Honorable Moya is saying, and I want to bring it to closure. Because if it was done in the last regime, I don't believe in a government institution like this one. There is, do we have a gap? So there's continuity of services. It is only leadership that goes for break because our business is contract.
Point of order.
So I think
Madam
somebody should tell us, the way Honorable Muya have just said, we need a full report. What was the money meant for the 70 million that you have already paid? Who supplied? And who approved for that debt at the same time?
So
Chair.
Honorable Chair,
Point of order, Madam Chair.
That I help
Yes,
also.
what is out of order, Honorable Chepkonga?
Madam Chair, information that comes to this honorable house is information from the government. Now, when the CEO and the CEC are not giving us the same information, then whatever they are telling us should not be admissible in this honorable house, Madam Chair. So that please, I'm asking you not to encourage clarification, explanation, or submissions if the government is divided. Thank you, Madam Chair.
Thank you. Hello.
Through the chair.
Good afternoon, members. I think let us close that chapter. Honorable Chepkonga has led the way, how we are supposed to deal with it. Let the executive do their things before they come here and speak in one language that we will all understand, because I believe when the CEC is here, he stands here on behalf of the cabinet. And cabinet and their chief officers and their doctors are one family. They are supposed to be speaking one voice, but not contradicting when they come to this honorable house. Members, our debate is live in our televisions, and that is what we want to protect the county assembly, not to come and accept such cases. Honorable, what do you have to tell us?
The issue, thank you, Madam Chair. The issue of NHIF, I need clarification about it.
Can we get clarification on NHIF, and then members allow me, after the NHIF question answered, we go to agenda number 2.
Kindly.
Mary Koredi, please let Daktari answer what Honorable Kipchumba asked, because if we add another one, he will just forget.
Okay. Thank you very much, Honorable Chair. To respond to your question, 2 months ago, we started, there was a challenge in the facilities when it comes to claiming NHIF, where the keenness in claiming for NHIF was not it was not proper. So we started a training
which we have trained the records officers. We have trained also the facility managers to make sure that the claiming from NHIF is optimized. Secondly, there were things that were lacking in the facilities which we have just procured. We're in the process of procuring. That is the biometric scanners from NHIF. Today, there is a training on Edu-Afya, claiming Edu-Afya to the facilities. Most of the high school students were not, their claims are not being passed because some currently NHIF needs the biometric scanner to be able to at least claim the NHIF money. NHIF has a contract with the facility, so the money is usually paid directly to facility. That is another thing we are doing as a department to make sure there is proper healthcare financing. Thank you.
Thank you so much for answering those questions. What we have asked in the, drugs is what members were so much concerned. I even thought we will only use 20 minutes because we already had drugs. But because of those issues that are affecting the department and the drugs that our people are using, that is why it has taken us 1 hour. Honorable Keitany and Evelyn, please.
Okay, thank you, Chair. I wanted to know the purpose of Koti Care. What is it intended for, and what is it serving?
Let me answer that before the chief officer answers. I think it's an introduction of NHIF, and because it has not been brought to this house for a policy, then it should not be a subject of discussion. Please, just allow me that for today.
Thank you, Chair. I think this is going to be the last question on this issue. There's something that we were given, the one that shows the figures of what they supplied. And I wanted to know, is it for the 2023-2024 financial year? Maybe it's good at least if I can get that answer so that I can know what I'm asking is correct. The first quarter?
The first quarter, November, that means it was 2022-2023.
Yeah.
To January, I believe. And then from May, I think the first November, January, and May are for the last financial year. And this financial year is August, the one which was procured just the other day, and I believe it's the one we received today morning.
Maybe through Chair, I just wanted to know, the trucks that you are flagging off today, was it under the financial year of 2023-2024, or it was for 2022-2023? Is it for the last quarter? The one that you ordered, that is for 77 million?
It is for the first quarter, which is August. You can see August there because we are in now quarter number 1, quarter 1 of 23-24.
So we are not seeing the first quarter for 2022-2023. Anyway, still, another question now that it means this one, the first quarter is for this financial year, which is good. If they have ordered and the trucks are already with us, it's okay. But I had something like that the figure was less by 5 million. According to my calculation, it's like the total order value was 59 million. The pro forma invoice, which I think it is the total value of the trucks, is 40 million. And then the figure should be 19 million, not less by 5 million of what I had.
Okay. What I heard them say is they procured medicine worth 40 million, but they supplied less by 5 million.
Exactly.
So we are still, the KEMSHA still owns us drugs worth 5 million.
Yes.
Is that what you said?
Yes, correct. But that is, Honorable Chair, that is not to say that drugs have disappeared, but it is that it is in the form of the syrups, which or the leader of majority was saying was a shortage in the other order. But this time round, we have also a shortage because they are distributing across the country. So that will be coming. The syrups is called
okay, Chair.
paracetamol syrups.
Now,
actually.
okay.
I'm done.
You're done.
Yes.
Okay. Thank you, members. Allow me to close that agenda number 1 by not only asking a question. This is just something for your consumption. What happens to medicine that are expired or almost expiring? Do you return them to KEMSA?
What the CEO was saying,
or
Madam Chair.
or you just dispose and we go?
No.
What happens?
What happens is, Madam Chair, because there is some tracking of some sort, although we are not computerized in tracking the medicines, but the sub-county pharmacists follow it up with the unit or facility farm techs or pharmacists to ensure the expiry dates of those drugs they receive is monitored so that what the CEO was saying are redistributed.
Okay.
So nothing expires because we are able to redistribute.
Okay, thank you.
Even 5 months before it expires.
Okay, thank you. Members, let us go to agenda number 2. I believe we have exhausted the issue of drugs, which was a thorn on our flesh. Agenda number 2, members, I want to request you to leave it for us as a committee to handle it, because quarterly report is always meant for the department to go through and then bring a report to the House. Because of time.
Side, that is not a request. All departments should submit quarterly reports to the county assembly so that they can be dispensed by concerned committees. Thank you.
So the quarterly report, I am requesting you, all of you, the CEC, this one we will handle at the committee level because it's supposed to come to our committee. Let me say this, the way Honorable Moya has just said. Let this be the last time as requesting for a quarterly report. It is a mandatory, it is in the constitution that quarterly report must be taken to the parliament for discussion on a timely basis. It is not a request from the assembly. It should not even come to a place as a request. Next time we do a request, we will summon somebody and put a flower here to show them the door. Because we have business, other business to do, but not doing what you are supposed to do constitutionally. Members, allow me to go to agenda number 3. The status of casuals and healthcare workers. I want us to take the shortest time also on this, about the casuals and health workers. Members, before you answer, the challenge we have when the casual contract were terminated, I don't know if that's the right word that I've used, we realized that all the hospitals were grounded. We had complaints from cases, we visited the hospital, Burnt Forest. Most of the hospitals that have been running 24 hours, they were not running 24 hours. And most of the hospitals like Ziwa, we got some complaints that people are queuing since morning, just because we have 1 or 2 clinical officers, and maybe nurses are 4 or 3 during the day and at night. So what do we give priority as was in Gishu County? Even if we say we want to stop casuals, why do we have casuals in the first place? If it is necessary for us to, not necessary, but if it is a must that we have casuals, why don't we employ them in terms of, because we need them. We have seen the problem we have gotten when the casuals were terminated. That means there is need in this was in Gishu County to employ nurses, to employ clinical officers, to employ pharmacists, to employ lab technicians. Those are, according to me, are essential services. The casuals, which is the watchman, the cleaner, the facility itself can pay for those casuals. It should not be subjected to the casuals of the county government of Uasin Gishu. So that when we talk about casuals, we know who are these casuals. In the last report we were given, we had so many casuals as social worker, nutritionist, and in that facility you get about 4 casual workers who are nutritionists and 4 social workers with only 1 doctor or 2 doctors and only 4 nurses. Who are we supposed to give priority? My humble request as you answer us, our CEC, please, if we need this staff, can we employ them?
The answer, Madam Chair.
Let me give members to react and then...
No, I'm giving direction. The answer they give us will either invite us for more questions or we rest the case there. So I hope they have arranged their questions in a way that it will be satisfactory to everyone so that we take the shortest time possible. Thank you.
Honorable Muya.
Yes. Thank you, Madam Chair, honorable members. I want to give a background of what happened when casuals were stopped. You remember what the governor said in Mombasa. The reason why all casuals were actually stopped was because the numbers were kept on changing and the value for paying casuals across the county, not even in health alone, kept on changing. And so it became difficult to manage. The idea, which was actually the new administration's intention, was to regularize all casuals, those who have stayed for long, interview them, and then employ them. But it could not be possible because it kept on changing. Now, I'll give you the landscape of all casuals, which is very quickly. There are casuals which are employed by government. They are called UHC casuals. These casuals the other day had issues, but the government has renewed their contracts for 3 years, and some have gotten letters, some didn't get letters. These are 221. There are no issues about these ones. These are government people. When they go away, government replaces them. And they are actually they could be doctors, they could be nurses, they could be farm techs, and so on. All cadres of health professionals. These are government. Number 2, let's now come to the casuals who had been contracted for 2-3 years over the years before we came. These were 44 of them. These were nurses, these were clinical officers and so on, and all cadres of people, and there were 44. There were other casuals who were assisting in various departments of health, and they were doing various works. They could also have been nurses or clinical officers and so on and so forth, but they were employed at different times. That is before we came. I'm now talking of casuals which we found. There were 380. Now, remember the conversation we had when we said we have 299 members of staff, mainly nurses, clinical officers who have left the county. And then I brought in the request, 299 of them, and then eventually the cabinet, the CEC, approved about 80. We ended up actually getting around 80, 90. You remember this is now recent. So that gives you a total of 544 minus the 221 UHC casuals. Remember what Madam Chair, you are saying, casuals which are employed by facilities. They are mainly watchmen, cleaners, gardeners, people cooking and so on. There were about 66 in the head count. I'm now giving you results of the head count when we did it. So plus that 66 gives a total of 610 casuals who were stopped from the facility. And then, of course, other departments stopped there. So in total, it was coming to around close to 1,500 casuals stopped across the county. So health, we were having exactly 1086. So in health, we had the highest because we had 610. Madam Chair and honorable members, of importance now is how do we get
Point
back.
of order, Chair.
Yes.
Madam Chair.
Honorable Amos.
Thank you, Chair. Madam Chair, I just want to maybe get clarification from the CC. You have said that a total of 1,500 casuals were stopped across the county.
1081 actually.
Not 1,500?
I have corrected.
Oh, now, was that from the Department of LD alone or the different department?
County-wide.
I thought he could have reported the as per the department.
No, I was just giving background.
Oh.
And I've said health is 610.
Okay.
Yes, health is 610.
There is also a point of clarification, Chair, Madam Chair. The CC started by saying 200 and something for government.
That is the UHC.
So that is county or national?
It's paid by the national.
Okay.
Paid by government.
That you know, we have county and we have national, so it was for clarification.
Paid by the national. Hawa ni wale wanaitwa wenye wanakuwa kwa mashinani wakichukua
under
information.
universal health coverage,
Yeah.
government gave to all counties. Now, what is important?
I think, Chair, as PSM Chair,
Yes. Yes,
and
yes, Chair.
even you are the witness recently, that was it was on Thursday. What we caught was that the casuals under the Department of Health was 423. The recently employed were around 86, but before you had around 300 and something. So sometimes I think it's good we get the facts, unless if we have supporting documents that maybe if the department can tell us maybe Siwa we had 20 and then you go something like that, the way we got from the Department of PSM. Otherwise, it's not good to say roughly or maybe this figure.
Maybe
this thing is life.
To fertilize that point.
Honorable Muya, just wait.
No,
Honorable Koreti.
Not to fertilize that point, is that whenever all these figures the CC is giving, they need to table the document so that you can interrogate further as a committee on the same. Thank you.
Honorable Koreti.
Thank you, Chair. I think when we were actually requesting for casuals, we were requesting in terms of those who were paid by the county government of Uasin Gishu, not casuals paid from other quarters. So kindly give us the casuals that you were actually committed to paying them. And we had requested, if possible, you give us per facility, because we really want to know which are these facilities that you are taking care of and which one are these that they are taking care of themselves.
Thank you, Madam Chair. If I may present the same document, because
I want you to present the same document because yes, on Thursday we had a committee with Public Service Board, and what they told us was the casuals in health department were 423. That is the number.
23.
Around 423.
Yes.
And
that is
you are telling us you are telling us 610. So if you have the document, please can you table so that we can interrogate more?
Yes.
And as you answer us, how many staff do you exactly need so that we don't have that gap?
Yeah. Let me use this, Madam Chair, as excuse to say. It shows the ID number. It shows where details of this are. And I'll tell you why you are saying there were 423. These 423, I'll tell you what they are. Now, there are these ones which were on contract for a long time. Yes. Sorry? Let me repeat. Thank you, Honorable Member. Let me just say, the first document that I presented is of casuals who are a total of
380. Okay, so we have 380. We have another sheet of casuals showing casuals who are 44. Okay. 44 are given in. It is P66. Okay, that's 44. I'm also presenting a document for the UHC, which Honorable Corretti is saying you want the ones, but it is important if you also know the UHC, where they are, what they are doing, and so on. Is here, UHC. I want to give you also the document that shows the casuals who were employed recently, as recent as was it. Okay, that was the most recent casuals. 78, it had gone up to 80, 90, 120, but I have 78 here. Okay, so that those are Honorable Chair. If I may sit. Now.
Thank you for stretching yourself. Please continue. Members, you have the document. I continue.
Now, Honorable, let me use this one. I think this is okay. The 424 you said, 423, you add 44 plus 380, you get 424. So maybe one disappeared on the way, but that is how they got 424. So we were adding that time. That is the number we gave it to Public Service Board. It was 424, but I think one of them was engaged on permanent and pensionable terms. So we have 423.
Was you added the UHC?
No. I added the recently employed. Which is 78, and I also added the casuals in the facilities which were employed by the facility committees.
The casuals?
The casuals unpaid by them, most of them.
Because what I also expected, CEC,
yes,
you have done you have done a good report here. That Janet Chepkemboi from CAPK with the ID number, and these are casuals, isn't it?
Yes.
All
of them are casuals.
I wish time of engaging them would have been indicated also, so that we can know who are there that they have been casuals for more than 6 years, 7 years, and who came recently. It could have been much better, because I remember I'm the only MCA who has the cemeteries.
Yes.
In the whole county, apart from we having one in Yamumbi. The young men digging the graves in my ward, some of them are casuals for the last 7 years, and they have not been confirmed.
Yes.
So I would have liked if it could have been specific, but not for now. Maybe for next presentation.
Or maybe Honorable Chair, if I may add is to say, we can improve on this document by telling our HR people, because you can see the person who generated this document is from HR, just to tell them now, go back and add when they were engaged.
Exactly. Honorable Chapkonga?
So it is easy.
I have a question, because do we have casuals?
We have casuals when now, Honorable Member? Now?
Yes.
No, we.
Yes, what Honorable Chepkonga is asking is, do we have casuals in our facilities after terminating their contract the other day? The answer from the CEC is yes.
Yes, we have.
We have them. So what we want to know, CEC, is, are there mode of engagement? That is one. How many in every facility? And were they approved? Because it is the public service management that stopped. Were they approved when they were told to remain?
To stop, yes.
To those who remain for them,
Yes.
because those were essential services.
Yes, yes.
Were their names taken to the public service board so that they can be considered for payment, or it was only verbal but come back to work?
Good question, Honorable Chair and members. You see, the way all casuals were stopped by, it was stopped by a county executive committee or cabinet, because it was agreed that we stop all casuals across the county. Now, in the letter from CS, because CS is secretary to cabinet, in the letter from CS to CEC for PSM, the message that was left out, and that message, when the CEO of PSM wrote to our CEO of Health, did not include the remaining bit that was part of the cabinet decision, was to retain people in the facilities, because they were saying those ones who are doing essential services. Like I told you, people who have maternity, they needed somebody to clean the linen, somebody to cook for those people, somebody, we needed security, somebody ground. So that is the bit when the circular from CEO of PSM reached the other people, it did not say retain the people in the facilities at the lower ground to give essential services. That is the bit. And that is why when I came here, Madam Chair, you asked me, and I think it was Muya who was saying he saw nurses with brooms cleaning in facilities, and then I said, no, that cannot be true. Nurses cannot do that. It is politics.
Point of order, Chair. Our CC.
Yes, ma'am.
Kindly take it from us as honorable members. It is not politics. A very good example is the first, the biggest facility in Kipsomba. That is Aqua. Has no cleaner. Even in this record, we don't have a cleaner. So when we talk of nurses doing the cleaning, they do it.
I stand corrected so that we make progress. Let me
and
say
again,
yes, that could be possible,
I've
Madam
not finished
Chair.
my point of order.
Yes.
When you come up with such a list, I wish the order could be per facility. When you talk of Chemororoch, you give us the workers in Chemororoch. If there are two, you say a cleaner and a watchman.
The 66 of them.
The Chair, point of order again. In addition, I just want to ask Waziri if he's aware that mapusu, kuna mapusu anatumika kufanya usafi Kamalel Health Center. I know you might have had a different report on other facilities, but are you aware kwamba kuna mapusa anapewa kazi ya kusafisha? And then in this list again, I'm aware that in Kamalel Health Center, around 3 casuals were stopped, but they're not appearing in this list. So I don't know whether that facility has been formally recognized or still assumed as a corona isolation center. Thank you.
Maybe as a follow-up to that, Chair.
Yes, Honorable.
I think
Thank you, Honorable Amos.
The list of casualties is not conclusive. We can confirm that because, for example, you know the famous gateway that you have not been giving money. This is a facility that the department did as good by just starting it. But those cashiers, since the inception, they have never been paid even a penny. And you gave the in charge an okay to hire a watchman because we have equipment in that facility. We have a cleaner. But I can tell you, they have never been given. And I think Luvai can attest to that. And they have not been captured to this. Who do we call these people? Who do we call them?
So that I don't forget, honorable members, through you, Chair, let me
Yes,
answer
yes,
quickly
yes.
because I might forget. Now, the Mapusu, the people who are in Kamalel, maybe the CEO can answer because I'm not aware that we have Mapusu there. Number two, I have said at the closure of all casuals, the cabinet picked at that point, and we asked our personnel officer to lift and give it to us. So if people have been left out, we are amenable to actually making corrections with our personnel people, and the CEOs are here. They will do corrections, and then we get the right people who have been left out. Now, remember, even for my
Maybe
memo,
to make it easy, you don't
Yes.
explain further. Which personnel can the facility in Chad see so that we can communicate, because there is a gap. Which exactly?
There is a memo which I released because there was a gap here through the chair, and you know, even you people, you are here and you say it now. People are not working because they are not yet given authority to be engaged, and that is true. As chair said, even Public Service Board has not given authority to engage anybody, but we said the 66 who were there before casualties were stopped, let them continue. That was why my memo was written. We said the ones who are there, 66, let them continue. So when the honorable member for talks about Chemoset, Kipsomba, says there is nobody, I can't help because we just said the people who were going on at the time of stopping. So if they are going to engage, is when now we go to the route of Public Service Board through cabinet again, and then people will be engaged at that level for the people to assist the facilities.
Madam
Thank you, thank you.
Madam Mwenyekiti.
Thank you,
Madam Mwenyekiti,
CC.
naomba.
Kuna ruling nitakuwa nataka kutoa kidogo. Haya, nataka niseme hivi, kuna jibu ya Mabusu, I want it answered, but before you answer, I want to tell the CEC, Honorable Leader of Majority just raised a concern, and Honorable Muya, that this document is not complete. So I want members, should we continue debating on a document which is not complete, or we defer it for another day, and then they give us a comprehensive report which has everything?
Chair.
I just want an opinion from members before we move on.
Chair.
But you will answer us the issue of a casual, these people who are the Mabusu, you know?
Chair.
Prisoners.
Chair.
Let me give most bridge first, and then I come to you. Yes.
Thank you, Chair.
Mheshimiwa Kimayo.
I think that ruling is okay because the list I have here, that is called C92. Okay, this one, the way it is factored in, I see most bridge you only have one. So Tarako has only two. So and then I'm told these are, I mean, he was saying there were 60 contracted, isn't it?
Yes.
And this is the list here.
Yeah.
So I think what the chair is, your ruling, this one is not conclusive. If most bridge, the whole of most bridge, we have only one, you can see we really have a problem.
Chair, what I would say is that kindly let your ruling stand. They go back. They know the number of facilities that they are procuring drugs for them, and they know those essential services must be given to the community. Let them give us the names per facility, and even write their contacts here. The reason why we would really want to confirm from them by calling them, because sometimes you may give a list of this kind, and the same list, the way you said, the governor stopped casuals because they were seeing there were changes every time a new list was coming in. Somebody could have been drawing this salary for himself. And where does it emanate from? It is from your offices. All those changes that are coming every month, every day, are coming from your offices. So the person who actually committed that crime should be held culpable for that. at the end of the
Asante.
day. Thank you.
Thank you so much. Honorable Kapkea.
Thank you, Chair. Chair, here we have two issues. The first one is it's not even about the number of casuals in our dispensaries, in our
facility,
fields. Our main agenda here was the casuals were stopped, and it is essential services. They were supposed, for me, it is good if you can discuss first on the status of them. Are they going to come back? Those who are now in our facilities, what criteria was it used? And about nurses and the rest, when are they coming back? Number 3, are they employing the new ones or they are recalling the old ones? So that is basically what we wanted to hear from the department. Not even about the number of that one. We will make it another agenda of another day. But the main one is the issue of casuals. When are they coming back? Or and they are not coming back, the new ones, when are they going to employ? Or they will not be there.
Thank you. And see, on top of that, when we say essential services is the cleaners and the watchmen, I don't know what are we supposed to call a nurse. According to me, it is the essential service because that is the service delivered direct to the patient. And they were not recalled. And the members, the critical services, let us even give it a better name, critical services. Yeah? And they were not given priority. What are we doing in Uasin County? Are we really serious on service delivery or we are on political delivery? Because when we see a list of casuals here, you see drivers 1, 2, 3, 4, 5, 6, 7, 8, 9. When the drivers are 9, I would like to know from our department, how many vehicles do we have? And yet, at our yard here, we have so many drivers sleeping and doing nothing because there are no vehicles. Why were we engaging more drivers than nurses? Why were we engaging more drivers than lab technicians? Yeah? You know, that baffles me. I don't know if members, you have noted that.
I want to add that.
And then you go down there, you see program officer for alcoholic, social workers. What social work are they doing when a patient is not even coming there because there is no doctor, there is no nurse? And my humble request is so that you can answer us. When we will be going for when we will be engaging our new either casuals or employment, let us approve first the organogram that you want to use in the department. If we have the organogram of the Department of Clinical Services and Preventive and Promotive Services, I want that organogram to come here first for approval before the employment is done. Because we don't want just to employ because we want to employ friends and relatives and who knows who. But we want to employ that person who will give services to the people who brought us to this house. Thank you.
Ongeze kitu.
Yes.
Madam Mwenyekiti, kopi yao ambao ni C92. C92.
You know the copies have not even seen what we are discussing here.
Unajua, na ninasema kama Sergeant Atam ofisi yako na secretariat yako hawajui la kufanya, itakuwa tukaze macho kidogo, kwa sababu members hawatajadili mambo ambayo hawana. Asante. Lakini asaidiwe, tuko na ofisi ya wengi katika Sergeant Atam's office. Nataka kusema nini? C92, kama vile umeweka swali lako nzuri, kuko na wale wakatoa memo kwamba watu fulani waendelee kikazi. Na kwa sababu ya kuengage hawa the C92, na naona ni idadi ya watu 78. Nakumbuka walikuwa wametuambia kwamba katika kaunti hii tulipata nurses wengi ambao walitoka nje ya nchi. Na kwa hivyo facilities zetu wakabaki bila watu wa kupeana huduma. Wengine wametutangulia binguni. Kumaanisha kwamba watu wetu wanapogonjeka hawana watu wa kuwahudumia. Hii sekta ama idara ya kupeana huduma ya afya si idara kama nyingine yoyote. Sijui idara hii wakiongozwa na waziri, je, walipresent kesi yao iwe tofauti na idara zingine? Kwa sababu ni kero kuona kwamba wanasema kwamba tuendelee na hao wale ambao wanalipwa na AIEs, lakini huduma hatuna watu wa kupeana huduma. Na ndiposa unaona facility fulani walipewa nurse, wengine wakapewa watu wa orthopedic whatever, huduma ambao haiko mahali pengine. Je, tungetaka tusikie zaidi wameongelelea jambo hili mpaka wapi? Tutangoja mpaka lini? Kwa sababu watu wetu wanataka hii huduma kokote kule. Ningetaka nisikie wameongea kiwango kipi, kwa sababu si haki na haitakuwa haki kusema kwamba kwa sababu tumesimamisha cash was mpaka wale wanapeana huduma muhimu tuwasimamishe. Si haki.
Asante sana Honorable Muya, and my final request is, before you do advertisement of nurses and all that stuff, please let us know exactly what you want to advertise using your organogram. Because if you imagine the way we expected last time that we want casuals for the hospitals, and unfortunately the casuals we are given here si wale wenye waheshimiwa wanasema ama yenye tunahitaji, then we will not accept. It is better we will not have them approved than approving 1,000 drivers and 2 nurses. So tell us what you approved in your budget, in your cabinet, and what also you demand for the department. Because this is a department not like any other department. Even when we are doing our budget members, remember, the department that takes 60% of budget of Uasin Gishu County, it is health department. Then why are we not given people to work for the same department?
So, if I may ask, if I may answer, Madam Chair, honorable members, on the last one, what have we done as a CEC? What we've done, we've agreed. As it is right now, the budget is not balancing. It's not balancing to the tune of 1.3 billion. And that is a discussion in the supplementary, which will be coming to here. Part of the biggest problem which we are grappling with is the issue of staff. And that is why we are saying they need to balance. The 2 biggest departments that require a lot of staff is health. We may need about 200, 150, 200. Another department that requires staff about 150, 200 is agriculture. Those 2. The conversation that has been agreed in cabinet is that we are not going to go the route where some 2 people were looking themselves in a room and employ people and load themselves over everybody and then bring people to be paid as casuals of health. So I agree with you, madam, that we will have a conversation where everybody will
Order,
be
Madam
involved.
Chair.
We will need that order.
I want to appreciate Waziri for your sincerity and honesty. Apparently, honorable colleagues, it seems there is a contest who has muscle to employ the number of staff. That's why you said it's not about 2 people closing themselves in a very nice room and doing their math there. Nonetheless, Madam Chair, again, I just want Waziri to clarify. When he says it is not balancing, what is the meaning? Can you substantiate? What do you mean by saying the budget is not balancing? And also, how would you wish this house to assist you to balance the budget?
Okay. The budget is not balancing, and it is an executive matter that it must balance before it comes to this house. Remember, the timelines of that budget, supplementary, there are timelines. And so we are working hard to ensure it balances so that the timelines within which we need to bring it to this house must be able to balance. That has nothing to do with casuals.
A point of information, Chairman. Maybe to inform Waziri and
that
House.
information, just give us.
Yes, maybe to inform Waziri and House, there is no timeline for supplementary Waziri. There is nothing like timelines in a supplementary. What has timeline is the budget. Also, what you are using Waziri for maybe operations is in the current vote, and we normally charge that one as a first vote in a budget. What is not balancing maybe is the development vote, and there is no relationship between mostly development and the operations money. I don't know if I'm making sense, Chairman.
I stand corrected. You are right. I was mixing terminology. Remember, I'm not in finance, but I'm also picking and piecing together. So thank you for the correction. Now, let's go back to casuals. So what I'm hearing from the honorable members in this house is that this casuals thing of health, we should never go wrong.
See, I had made a request that the document we have is not complete.
Yes, I got that one.
And the information members just gave you is for your own consumption.
Exactly.
So that when you come back to this house with the same report, you would have fine-tuned and bring the right thing that we want. I didn't expect us to continue again with the issue of casuals, because the document we have are totally incomplete the way members are raising their issues. So I don't think it is necessary for us to discuss something which is half-baked. Deputy Speaker.
Most obliged. So,
I'm not discussing, sorry.
Most obliged, Madam
Yes.
Chair.
The only thing I wanted an answer, I will not forget. Let me just give our Honorable Deputy Speaker to say something, and then back to you before Dr. Wangwe tells us about the casual at Kimalel.
Yes, thank you, Chair. Maybe I've seen Waziri so much in pain explaining who is employing for his department. Just a reminder, last Friday we were here with the Department of PSM, and PSM confirmed that each department is fully concerned about who they will employ, because they have taken back issues of you are giving your, as a department, you are giving your need, because what they told us was that they will be going to employ the castles on need basis. And this point in time, I would have expected the department to be in their fingertips that this is what we have tabled, that it is our need. We have a need of such a kind of staff that we need in our department, so that it is not a push and pull back, right, left, center. PSM say that the department is fully concerned. The department is here is talking about who is employing for you. So where are we? Are you fully owning your employees as a department, or you are still being managed?
Just to answer it, thank you, Deputy Speaker, Honorable Deputy Speaker. I want to say that, yes, the problems we had as health was people were employing for us that time. And so this time, the conversation, and that is, I think what you are right when you say PSM have said, health will be able to do their own discussion, and we will do it under the guidance of the chair. So we are going to do it. There are members of health, of the county assembly, members of health. We'll do it with the department, all members of the department. We agree what we want, what our needs are, even that organogram, whatever it is, until we are happy, all of us, that this is what we want for health. Yes.
In that respect, honorable members, allow me to do another request letter or invitation letter for our CEC to be here in 7 days. I don't know if 7 days is enough for you to do a report for us, for the casuals,
Honorable Chair,
so that we can.
Yes.
7 days is okay.
7 days is okay. The entire team is here, so they are also listening. In 7 days.
Then Monday next week, we are supposed to be here again discussing the same. She will do a letter, a formal letter, because we don't want to do it verbally.
Maybe we can ask the two CEOs so that I am confident that they are with me in this.
They are with you. I don't. There is something I'm. Anyway, thank you.
Chair.
It was a break. It was a break. Let us take it lightly.
Yes. Chair, PSM.
Thank you, Chair. Maybe now that the department is here, I think I will use this opportunity to ask a question that we tried to ask the Department of PSM, but we were referred back to the Department of Health. The other time, I think you had some money for the casuals, the recently passed budget, the one that you are now thinking of doing supplementary. Can you confirm that? And if yes, what are you planning? And another issue, Chair, the other time we were told that it's like you have agreed as a department that you will be paying your casuals. And the way you are going to pay is that the committee or maybe the facility will be paying the casuals. I don't know, are you in a position to pay those casuals in case if they continue? And on that issue, I know very well, and this one I'm talking about the facility in my ward. I know one that maybe they will not be in a position to pay their casuals. I don't know what you are going to do for those casuals under those facilities. If it is true, you have agreed that you are going to pay the casuals under your department, and maybe the facility will be the ones paying.
Chair.
Thank you, Honorable Keitang. And I think that's exactly what Honorable Baraswa said, that we want a facility with the names who are serving there and who are paying them. If they bring us that one, it will just answer your question. Honorable members?
Yes, maybe Chairperson. The CEC Chairperson requested for the confirmation of the Chief Officer, and it is good that they are here. Why don't they just confirm?
I'm still waiting for their confirmation, but somebody just shoot a question before they answered. So I believe they are
all right.
organizing on how to answer.
Then there is something Honorable Kapkea asked. I don't know if I did not.
I expected the CEC to answer us before we close this agenda of casuals. That are we going to recall the casuals, or we are going to employ new casuals? That is what.
Yes,
is that what he asked?
That is what, yes, Madam Chair, that's what Honorable Kapke asked. Yes, it is yes and no. Meaning, when we sit down as health and as the Department of Health.
Honorable CEC, Honorable CEC, we don't have an answer of yes or no. This is a house of law where we just have straight answers. It is either yes or no.
Chair,
we don't have
that word of it is yes or no was the same word that was used by the CEO Public Service when we raised the same question. It will be yes or no. That is the same word that was used by PSM CEO.
Very wrong, because it is not parliamentary language.
So maybe that word is something.
It is not parliamentary terms.
There is something with that word yes or no.
It is in the parliamentary. We have a yes or no. We don't have the middle of the two. So either tell us it is yes, or you say I will answer later.
Yes.
Yes, that could be, that one can be better.
Thank you, Chair. Yes, honorable members, I want to say that yes, that question I'm not able to answer now because we need to make further consultations with other stakeholders.
Thank you. That is a good answer, and it is accepted in this honorable house. I want Dr. Wangwe to answer the question Honorable Amos Kiptanui gave us about the Kimalel Health Facility. What's the name of this? Kamalel. Former Corona Center. But it is our hospital. It is no longer a Corona Center.
Thank you very much, Honorable Chair. Now, I'll talk about the issue of prisoner working there. They are allowed to work outside the facility, slashing grass and hedging the compound. If they work inside, then inside the facility, then it's a mistake. That is applied across, even at MTRH. Sometimes you get a lorry going there with the mabusu and they work around there. The problem, I think, in health is deep-seated. That is why we are looking at other options that have not been tabled here yet, and we are going to table. I have just mentioned on NHIF optimization, so that we are able to pay for the staff, so that the facilities are able to pay for the staff. And that is an exercise that has started. And I would also add to say that the whole department is aware that this issue is basically healthcare financing. That is why I have the issue of cash flows. Health being a consumer, with the budget that it has, it is not able to sustain itself, and it is not sustainable. Until the point we put everything open, talk about the debts that our facilities have, Turbo, Ziwa, not Ziwa, Turbo, district, and all these documents are in the office, and all the departments are in copy of the debts, and they are properly broken down. So another thing we also have to look at is that I think health really depends on all other departments to function. So it may depend on the goodwill of other departments so that health functions. We may be here as a department, but our hands are tied. We depend on public service management, we depend on finance, we depend on procurement, we depend on roads and public works, we depend on many other offices. If all other departments can understand the urgency in which health should work, then we will be able to deliver. But it boils down, I think, to healthcare financing. So in future, if we can come up with policies that ring-fence our operations as health, so that in case we have a budget, it's just not touched and no money is moved or reduced from our expenditure, then it can be, that can work.
Thank you.
Thank you.
Dr. Wangwe, I hope you are aware that all the policies emanates from the department. The business of this house is to take it for public participation, and we approve.
Yes.
When the governor signs it, it becomes a law for you to use.
Yes.
So unless you bring us the policy, we can't do anything because we don't know exactly what you want to do. So it is you people to bring the policy here, and then we give you a go-ahead to work with it.
By that, remind them in the charge sheet for the former governor about the Finland issue. The prosecutor was very clear that things was never approved
by assembly.
By the assembly. So whatever they are doing with Kotikias, without the approval of this house,
it's
null
void.
And void. Somebody should tell them again and again.
Honorable Chair, if I may respond.
Yes, can you respond on that? Because we want policies to guide you and protect you at the same time.
Yes.
If you do your things the way you want, then that day of...
Honorable Chair, I understand Honorable Muya's sentiments. There are several activities that have been happening in the department. Some are yet to happen. Kotikia is yet to happen. What happened was a medical camp that was done by well-wishers from across the county. It was just a group of well-wishers who came to treat the public. But of course, it was just well-wishers who came together to do a medical camp, free treatment to the public. But as we progress with that, what happens there is NHIF registration, which has always been an ongoing process. Also, the NHIF optimization that we are speaking about, it's an ongoing process carried out by NHIF. When
it will demand for us to have a policy. That is when it comes to the issue of maybe any other thing that will need a policy. We will definitely present, and we are working on areas that may need a policy, and we will present. The department through the office of the CEC will present. Yes, thank you.
I also expected you to accept our invitation because both the chief officers are here. I thought mumeongeleshana mutapatikana siku yenye tunahitaji maneno ya casuals on Monday next week. That is okay.
Yes.
I have a question so that we can close that chapter of casuals and whatever. This is not a casual issue. But when you were doing your introduction, I had acting, what's her name, Sarah. Then there's another acting. What is this that you are acting? If somebody has the capacity to work in that office, why are they not given position to work? Or we are waiting to employ a young girl or a young boy of my son's age who just graduated last year to be a director or to come and take that position without any experience. Why are we waiting and keeping? It's like everyone in the department is acting. What is this acting position? We don't have a clause to finish this problem. What is the problem, Mr. CC? Is the problem with the Public Service Board? Or is the problem with the Public Service Management, the PSM? Or the problem is with the department? Because it's the department who is supposed to say, we want this and this to be done in our department. What is the problem? That everyone is acting.
Chair, I want to
before I give another member,
yes.
Personally, if I'm given to act in a position, I will not work wholeheartedly because I know after all, even if I do all my energy here, nobody's appreciating because I know somebody else, Kapsoya will come here, Kemboy will come and be given that position, and I've been working here for 2-3 years. Because surely, I don't know. There's
Chair,
a member where
I also wanted to add one set of only one question, and I will follow from pick from where honorable member from my neighbor from Zerkoit. Yeah. Last time on Friday when PSM were here, we were told that all the facilities recalled cleaners and watchman, and the other one. So they can also, the department can also confirm that in all the dispensaries we now have cleaner, watchman, and groundsman. And also, Chair, on the issue of acting, I believe we were told that someone is supposed to act for only 6 months. And then from there, you are either team that you are permanent, you are confirmed on that position. So maybe someone has been acting for more than 6 months and you are still acting. And the human resource law is very clear that after the 7th month you are now confirmed automatically, not even supposed to come from the human. Thank you.
Thank you, Chair. From the look of things, at times there are some implied conversations. Maybe the CEO, the CEC is actually sitting alone. Could it be telling us something?
So that one of...
excuse me, members, I don't believe so because in all meetings that we have invited the CECs, many a times they do sit the way they have sat. I think they do sit that way because so that we can face them. Yeah? Because when Honorable Ngetich was asking point of order, you saw me turning, I am only thinking that could be the reason. I don't think there's any other reason. Let me just close that one at that point. Members, allow me to go to agenda number 4, which is number last.
A request, Chair, before you go there. I don't want
Chair, they've not confirmed that they are aware that all of them were recalled. And maybe the acting part of it, is it they have acted for only 2 months or more than 6 months?
Yes, Honorable Muya.
Thank you. When they will be coming next week or the day you will invite them or summon them, I would like one issue to come out very clear. Most of our facilities, there is no operational labs. Those facilities might be having equipment. For example, let me use Gitwe. Gitwe have the equipment needed for a lab, but they don't have the technician. I would like to see it coming out very clear. What as a department, they are not expecting the governor to address that issue, neither the public service management. It is them to say that these facilities are not fully operational because we are lacking these personnel as the technical people. I would like them come out very clear during that meeting, not today, that meeting.
Okay.
We want, why the members are asking this, we want to streamline the issues in health department.
Yes.
The way Kitwe is and other facilities. Can we have, before, and that's what I was saying, before you do employment, can we have the needs of every facility? Yeah? Can we have the needs of every facility so that we can balance from there?
I was waiting to hear the acting part.
Or the acting part.
Yes.
Now, there was something I did ask, and Mheshimiwa Kabukea also fertilized to know about acting capacity. Why are we acting?
Yes.
Let us lead these actions,
yes.
and we work.
Yes, Honorable Madam Chair, thank you, members. I want to maybe respond to the acting bit, and the way I responded is by saying to be elevated to a position of deputy director or director, you'll have to go through public service board usually. But before that, the head of executive or governor would maybe say, I would like to have so and so to be acting director of something. You can say that, he is free to say that. And then that what that means is until now the public service board invites that particular person or those people who are acting to come to appear before them, and then they are interviewed. And if they are found to be suitable, then they assume the position. If they will not be, then other people who are more suitable can be given.
How long are they supposed to act before they are called by the public service board?
It is ideally, as per HR policy, supposed to be not more than 6 months. So, but in our case, is very precarious because our case is because we don't have money. We have no money, like I told you. We are trying to balance. Even the people in the system who want to be given higher grades, doctors, people in this room and others even outside here, who want to be given, to move a grade higher.
It is not that they want to be given, it is their right to be given promotions.
Because it's long overdue.
Yeah, it's long overdue.
So, Chair, this is to say, we have to balance the money. And the money which we are balancing is to say, we need 200 medical staff, doctors, nurses, clinicians, and so on and so forth. Because I have not answered the question you asked, which you were saying, which is more critical, more important, the cleaner or the doctor or the nurse or the clinical officer. So the answer is, of course, the core business of health is to treat patients, service delivery. So we want to maximize the money in health, in the budget, to employ critical people, priority number one. So the next will be now promotion, maybe simultaneously we can employ other people and promote others to the next level. So that is when now the people who are acting can be interviewed, and if they don't fit, because you are saying maybe they're inexperienced or there are others who are more experienced and they can also apply, then the one who is more suitable takes over.
Okay, thank you.
So we have no problem.
Let me give Honorable Kimayo and then Leader of Majority so that we can close that chapter.
Thank you, Chair. I wanted to understand because maybe for the director I can understand, but for the CEO, the acting CEO, I believe there is a procedure for that.
Oh,
Number
sorry.
two.
Let me answer that
let
one
me
for the
answer that
acting
one.
CEO.
Please let me add another point,
Okay,
so that
okay.
you.
Sorry, I
Okay.
didn't know. Yes,
Now,
he's
if somebody is acting on a given position or capacity, is she or he going to earn the salary of that person? I mean, on that capacity, or the acting will just receive his.
Na active
And
bure.
if
Bure, hii ni bure, mheshimiwa.
Ni bure tu.
Ni bure.
Okay.
Hakuna Kiprotich
Why
cannot.
Dr.
But-
Kiprotich is acting or is acting on behalf of Dr. Joyce Sang.
Sang, yes.
Dr. Joyce Sang is on her leave, short leave. And in her absentia, somebody must be in the office. So Daktari, because he's the
Madam
director
Chair.
of the same department,
Sasa.
is acting in that office.
Well understood, Madam Chair. I want, at your own time, interrogate further the word of Waziri, acting Bure. When you were a chair of finance committee during the defunct council, I can remember that acting position were being given, attracted some
money.
Why in the government, county government, at una act Bure?
Let me answer Honorable Muya. It is by our making, because there is no law that says when you are acting in an office, you're not supposed to be paid. In our defunct council, and I stood for finance, staff, and general purposes. Anyone who was acting was paid. Yes, you have an acting letter in the office, you're supposed to be paid. I believe also Dr. Sarah is acting with a letter, not on a verbal capacity.
Even Kiprotich has a letter. So we can agree, Chair, that we go.
Kiprotich is still acting as a director?
No. For acting as CEO.
But CEO is only representing Madam in absentia, but the office is not vacant. Yeah? Anyway, our message is, can we make sure that we close those caps and make sure that when somebody has the capacity to serve us in that office, that is supposed to be an in-house arrangement.
It is in-house.
Yes, please.
So it's your Chair.
Thank you. So
I'm just following on my question.
Yes.
Is you a Bure?
Yes, is you a Bure?
And Chair,
So, Dr. Kiprotich,
as a concern
you
on acting,
organize to claim, please.
I thought when somebody is brought in to act in a capacity of a CEC or a CEO, he or she must be a CEO or a CEC. You cannot bring a director to act in the capacity of a CEO. You know the process that the CEO went through, the CEC went through? So the same person acting in that capacity must have gone through that fire. Thank you.
To add that, that is an issue that we interrogated in the last government. That for you to act as a CEO, Dr. Kiprotich, hear this well. Somebody who was vetted for a CEC,
Can you allow me to make a correction?
Yes.
Dr. Kiprotich is not acting on behalf of the CEO, preventive and promotive. He is standing in for her. He is standing in. He's not acting. So let us not dwell on something which is not there. I think it is only, the language we are using and the words sometimes mix us.
Let me
so it is
correct.
not supposed to be acting, but for his...
From the institution memory, it is good for them to know.
Yes.
The problems we had in the Department of Health, they were just picking somebody to come and sit on that seat as the CEO. And then the CEC was using what she was calling executive orders to tell the CEO, write a letter to transfer. We should not revisit that issue again.
Yeah. I'm
Please,
laughing.
and then we...
I'm laughing because
we have another committee we're supposed to...
Sometimes the CEO was told to write a letter to sack himself. So, mine, Chair, is I have not understood clearly this whole issue of casuals and recalling the casuals, it does not come out clearly, and I don't know what I'm taking home. First of all, the famous statement of yes and no is coming in because, Chair, we came across a letter from the CEO, or I don't know, it was from the CS, that internal memo that was saying, that was advising facilities to recall casuals. I don't know, CEC, if that letter is still active or it has been recalled, because when you say it is neither here nor there, and an official letter, government letter, has gone to facilities to say, please employ this number of casuals, and specifying the level of facilities, the ones that have maternities, the ones that have labs. It was very specific. So I don't know the status of that letter. Is it recalled? Is it active? Has those casuals been engaged? That process, did it go through the Public Service Board? I am lost, Chair.
Let me respond, Chair. I wrote that memo, and that memo is as a result of the meeting we had here. You remember when a member was saying he saw nurses cleaning in white clothes and so on, and then the confusion that had arisen was because there was no memo from the CEO to say the people who remained in the facilities. See now, the people who remained when the contracts of everybody else who was temporary had expired. That was end of June 30th. That was the cutoff point. So June 30th was the time all casuals in the county stopped. But the memo that was meant to guide the chief officers was to say, for purposes of health, which is also essential, and because people were saying now, if somebody like, say, for example, Moist Bridge, there is a maternity, or another place like Siwa, there is a maternity, and people have delivered, and somebody must cook for them, somebody must clean the linen, somebody must clean the rooms, and so on. What are you saying? So they said, those ones who are there, you see now, this again, Majority Leader, it should be understood within the context, because the facility manager may now go out of our way to employ other people. The idea was the one who was there assisting in that facility should remain. That is step number one. Step number two, that person has not been employed, because eventually when all casuals in health are employed, it has to go through PSM, it has to go through a requisition, must be done through Public Service Board to employ those ones. That is not to say those ones cannot work. They are continuing like the way they were continuing, but now they have to regularize through Public Service Board to be given letters and to be paid. Right now, they are not being paid, but they will be paid.
Geze hapo, leader, ukiangalia kwa hiyo internal memo, number 4, ICT stroke records officers. I don't know if that one was essential service than a clinical officer.
We included ICT because they said, like, for example, in Ziwa, there is somebody who is doing Linda Mama as people come in NHIF. There is somebody to enter in the records for recording.
But Waziri, this is an open check. This is an open check. Every facility will just recall the ICT and the records officer. I wish you could have specified that Ziwa, specifically Ziwa.
For Linda Mama.
Linda Mama, you know?
Okay.
It could have been better. But now this one is an open check. Everybody will bring back their people. And at the end of the day.
Chair, maybe
when
you talk of...
let me finish. By
Yes.
the way, Chair, what we have found out, there is now about 400 people from all facilities who have been brought, and this was the fear of CC, that these people have come, 386, who are new people, and we have 66. We were saying the 66 who were continuing in the facilities.
Sasa mtuletee report
Chair,
nzuri next
Chair,
week. Yes, madam,
What I
tukimaliza.
wanted to say is this, when you talk of Linda Mama,
Yes.
you know one thing, the problem with the department is one. You have not considered all your facilities. That is number one. You have a skewed kind of workers to other facilities, and you are overlooking other facilities. For example, we have maternity in Tarakwa. People deliver, but we don't have a cleaner. Whom do you expect to clean? We don't have a cook.
And that is why,
so those are
Mheshimiwa,
some of the things we are saying.
And that is why, Mheshimiwa, I did request that
Kindly,
this casual report is not complete. And I made a request that can we allow me to,
chair,
when I'm speaking, Madam,
I freeze.
Yes, you're supposed to freeze, and you know that. Yeah? We cannot make the house unruly. That's why I did request that, because this report of casuals is not complete. Can we defer it for another day? So that they come back with a fully prepared report, with the input of what you have just told the department. PSM, what do you have to tell us?
Maybe, Chair.
Point of order.
Maybe, Chair.
Point of order, Chair.
It's my time. Honorable Moya, it's my time.
Point of order.
He was on order also.
Unless otherwise others are special than...
He was also on point of order.
From the leadership desk, we had given timetable of how we are going to conduct today's business.
Chair,
as we are speaking, Honorable Shah, we have officers from executive for the roads department outside waiting. Give us direction on how we are going, because we have exceeded your time.
Yes, Honorable Shah, so that we can finish. You know,
You know, I'm getting now confused, because the way I know, with the experience of those 6 years, I know Chair has the power. So, but anyway, all in all, it is the issue of casual. Ingawa hata ni chipu, but it's a burning issue as Chair. Umeandika barua Wasire. The other department ya PSM wanasema nyinyi ndio mtalipa wa casuals. Up to now, June kwanza muko na arrears ya casuals hawajalipwa. Mumeandika tu barua. Other facilities wamerudisha. You are talking of 66. What I know, the previous casuals walikuwa ni around 400. Wale wenye walikuwa. When you talk of warudi, you should know that there are more than 400. Hii nyingine 66 ni ile latest. So, it's good to be clear. You don't have to answer that, but I'm giving you advice kama chair PSM. Otherwise, itawaletea shida.
Sana chair. Nafikiri tumemaliza hiyo agenda, imetuchukua muda sana. I want to request members to give me now direction. We still have one agenda, which is very weighty. It cannot take 10 minutes, it cannot take 20 minutes. And we have another committee meeting which is supposed to be here. I want you to give me directions on the last agenda of number 4, which is we want to know the position of our health facilities, the procurement process. Yeah? Because you get a facility like Kibulgen was awarded tender and it was only 500,000. So I wonder, what will that person go and do there with 500,000? There was another facility with 200,000. So those are the questions that it can take us another 3 hours. I want directions from members. Tell me what we are supposed to do, and then I will lead from there. I have seen Honorable Koredi and then Chip Konga.
Thank you, Madam Chair. Now that we did not get what we wanted from them majorly on item 1 and 2, can we handle that together with this one in their next meeting? That is my proposal. Thank you, Madam Chair.
Asante mwenyekiti. Niliingia hapa kama nimechelewa na si kwa kupenda. Niliitwa kule kwa facility yangu inaitwa la Mayuet. In this case ya kusema contractor alikuja juzi and he was sent off. Aliambia rudi na lori yake na mchanga yake. Sasa hiyo nafikiri itabidi tuongee, maana
Haya, asante, tumesikia maoni yako. Wacha nisikie kutoka Honorable Amos, alafu nirudi kwa Muya.
Tutatoa maoni. Thank you, Chair, for being fair enough to all of us. I know we have a lot of issues. I want to second Honorable Chepkonga's position that the issue of programs in different facilities cannot be dispensed within 10 minutes. I want to support that. Since they are going to come back in the next 1 week,
okay, they
can come and present that one comprehensively.
Can I get Madam Koredi and then Yego? And then I put the question.
Thank you, Chair. As much as we allow them to come with a report next week, one thing that they should be able to know is that whatever we are having problems with is concerning 40%. And what you should put into your consideration is what was in the minds of the community, together with the honorable member, to have facilitated that amount of money before you went ahead to do procurement and in terms of tendering it out. What was in the mind of the people? That is what you are missing. Thank you.
Honorable Yego, DS is still.
Madam Chair, I want to agree with what Honorable Chepkonga and Honorable Amos have proposed. Honestly speaking, our sugar level is actually 1, and number 2, we have this committee which is also coming in. So I want to propose that we move this agenda and the issues remaining in the next meeting. And in the next meeting, I want to propose, Madam Chair, they also come with the list of all the facilities that we have in this county. And we also look at the casuals and the number of people attached to every facility.
Thank you, Yego. So in that respect, allow me members.
I want to make it
allow
better.
me members to put a question.
No, I wanted to put a question.
I am putting a question. As
There is a
many
very
as
burning issue.
of the opinion say aye.
Before you put
aye.
Chair, I wanted to say
yes,
that them as a department, you know, the issue of these contractors is that they have not handed over. And they know the procedure of a contractor to be taken on site. Whatever Honorable Goreti have said,
and Karim,
they need to do things procedurally. And because the views of the community has not been taken, they need to arrange with honorable member representing those wards on the date of handing over after ironing out what is outstanding.
Okay, thank you.
Thank you.
And for answer,
Maybe Chair.
There are things they are working on at the ground level. Can they put them at all?
I think Honorable Muya has just said that, Honorable Koredi. Don't repeat. PSM, what do you have to tell us?
I want to support you that we postponed until the next. But before that, I wanted to clarify on something. You talked of 200,000. I think the issue of 200,000 is in Circuit Ward, and that was Jeff Kanga facility. We agreed to put 200,000. Mwelewe kwanza ni raia saa zingine na kamiti ndio wanatupeleka hivyo.
Ndio tunasema wasipee tenda.
I am trying to tell you that sometimes we can even allocate 50,000 with some reasons.
Yeah, sure.
200,000 was for the completion of staff houses. Ilikuwa ina require 150,000. And I just decided, because of the issues, fluctuation and what, we decided to put 200,000. So sometimes, msiangalie fika na kusema what is this 200, it's good at least.
Asante sana. Members, wacha nishukuru. I have a small parting shot, but I want this mics to be switched off. It is not
It's